Dr. P.M. Gupta sir, please come on the desk. Dr. Matthew Burgess sir, please come on desk. Dr. D.K. Taneja sir. And Dr. Ritesh Rundu sir. Please give him bouquet. Matthew sir, please.
Yes, sir.
Lights on. Photograph का lights on का वीडियो भी आपको करनी है। मैंने एक बार देखते हुए हटा नहीं किया। मैंने एक बार कमी लाइट को। हाँ सामने, सभी सामने। जब तुझे ऐसे नहीं किया था ऐसे करते। फिर से करो
Also request to Dr. John sir, please come on desk. Dr. John sir. Dr. Mukesh Jain sir. सर उनका फ्रेम छूट रहा As our culture, to anything start, we have started with the land planning. So all the chairperson and faculty members come on this society of the land.
आप थोड़ा सा
सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा इसे बाहर कर लीजिए
भैया
Now we start the session and hand it over to Dr. Ritesh Rundu.
program there is up here.
Yes, sir. Yes, sir. Yes, sir. It will be. Sir, one more. Ready, sir?
थैंक यू
एक और सर, एक और सर. सर इसमें आँख बंद हो गई है सर. थैंक यू सर.
थैंक यू
अभी
ठीक है भाई, हम साइड से ले लेंगे.
Good morning all, respected seniors. Today we have assembled here in this workshop on clubfoot under the aegis of Bihar Orthopedic Association, and this is the golden jubilee of Bihar Orthopedic Association. A great moment for all of us, and we are at a great feast in Rajgir. So welcome you all again, all the faculties and delegates. Today we have teacher of teachers with us. So again, we have a great moment to learn a lot of things about a centuries old problem of clubfoot, where surgery which appears to be immediately, it is very demanding as well as gratifying to the patient and doctor, many a times is not the end result or end treatment of clubfoot. And plaster technique which has been practiced for so many centuries, still it is evolving, and we have reached to a place where we have a very good technique of Ponseti casting method. So dealing with all these intricacies and techniques of casting as well as variety of treatment with clubfoot, we have our eminent faculty and our teacher of teachers, Dr. D.K. Dhanija sir with us. Sir is presently working as professor and head in Arihant Hospital and Research Center in Indore. You are welcome, sir. Sir has many publications, many orations, many teaching sessions, endless, so it is difficult to enumerate. Again we have with us Dr. Matthew Varghese sir, who is professor and head in Department of Orthopedics in St. Stephen's Hospital, New Delhi. He has been director there. He has been associated with lot of PG training programs, faculty training programs, medical as well as non-medical, orthopedic as well as non-orthopedic. And as I was going through his biography, he is a real life hero of Bill Gates. Dr. Parmanand Gupta, professor and head from Chandigarh Medical College, Chandigarh, Government Medical College, Chandigarh. Today sir is with us. He is exclusively practicing pediatric orthopedics, has a good experience in clubfoot management as well as other pediatric conditions. He has traveled across the globe as fellow, as expert, and he has several publications. Today sir will be with us. He will be guiding us how to do Ponseti maneuvers, how to apply plaster, how to apply the Elizarone in clubfoot conditions. Dr. Arun Kumar, sir has not reached yet. He will be with us. He is a head, professor and head at SKM Medical College in Muzaffarpur. He has vast experience of applying chest in clubfoot. He will be sharing his experience on that. Dr. Ritesh Pandey, he is additional professor in AIMS Patna. He has fellowships from various centers in pediatric orthopedics as well as several publications in pediatric orthopedics. So you are welcome, sir. Dr. Shashikant Kumar is assistant professor in Patna Medical College and lot of experience in pediatric orthopedics. He has several publications and he will be dealing with just in clubfoot in his presentation. Dr. Jaswinder Singh, he is senior consultant in Paras Hospital, Patna. He has several fellowships, lot of experience and publications. So he will be sharing his experience in today's workshop with us. Dr. Saurabh Chaudhary is professor and head at Netaji Subhash Chandra Medical College, Beta. He has been consultant at several other places and had several publications. Dr. Shamsud Hoda, a very pleasing personality, and he is a member of several bodies of national and international national bodies. He will be sharing his experience with Elizaro in Clubfoot and myself. We all will be there in today's workshop for 3.5 hours, where we will be dealing with variety of conditions, various aspects of Clubfoot, basic techniques, basic pitfalls, and how to rectify it. Apart from that, we have members from CURE. They have given us foot models for application of plaster, bone models for demonstration, and we have representative from picture. They have come with the Elizarov set. Apart from that, SCT, Mr. Vipul has come with plaster materials. So we all are together in this workshop. So I welcome you all. I welcome, and I request my faculty, Dr. Ritesh Pandey, to start with. And we are all here. You can ask any question, any moment of time. We all will be here in this hall. Thank you.
Batsman of this session, and I also thank Team Boacon, Arun sir, Dr. Amaldeep, Dr. Abhishek for making me a part of this event. I will be speaking on approach to a case of clubfoot and the scoring systems that are used. So this is a very common scenario, a one-day-old child, and you get a call from NICU to evaluate the foot deformity in a newborn. And we all should be able to differentiate a clubfoot deformity from other foot deformities. So typically a CTV consists of forefoot adduction, heel varus, ankle equinus, and midfoot cavus. So these are the typical components. Now you can have a situation where all these components may be present, but that is not a true CTV. In those cases, it is possible to manipulate and correct the foot deformity and get a good amount of dorsiflexion. So those are positional CTVs, and they just need manipulation and reassurance. Next, a quick assessment is done to find out any associated anomalies so that idiopathic CTVs can be differentiated from syndromic and neuromuscular ones. The next step is to assess the severity of deformity by using one of the clubfoot scoring systems, and this scoring systems also helps us to monitor the improvement of by treatment, then pick up the signs of recurrence, establishing the prognosis, and deciding the time of T8 anatomy. So the grading systems can be clinical or radiological, and for this presentation I won't be going deep into the radiological scores because they are not very commonly used. In last 5 decades, number of clinical scoring systems has been developed, but the most commonly used are Pirani and Dimiglio scores, and we will look into detail about these two classifications. And there is enough evidence in literature for both of these to be simple, reliable, reproducible, and prognostic. So the Pirani score was developed by Dr. Shafiq Pirani in 1995, and it is based on 6 well-described clinical signs, of which 3 are in the midfoot and 3 in the hindfoot. And each sign can have a score of 0, 0.5 or 1. So that the total maximum score can be up to, it can differ from 0 to 6. And it is important that the foot and ankle should be placed in maximal correction before assessment, and a sequence of look, feel and move helps us to memorize the steps. So coming to these signs, the curved lateral border is assessed from the plantar aspect of the foot by using a ruler, and score 0 is for a straight border, 0.5 is when it deviates at the level of the metatarsals, and 1 is when it deviates at the level of calcaneocuboid joint. The lateral head of talus is palpated over the dorsolateral aspect of foot, and its reducibility under the navicular is assessed. 0 is when the talus is completely reducible and you don't feel the head of talus after manipulation. 0.5 is when it is partially reduced, and 1 is when the talus remains fixed and it doesn't move at all. The medial crease is assessed by gently lifting the foot to correct the adduction and assess the depth of the crease. Again, 0 is the presence of several fine creases, which is normal. 0.5 is 2 to 3 moderate creases, and 1 is a single deep crease and you are not able to see the bottom of the crease. It is so deep. Similarly, posterior crease is assessed by gently correcting the equinus and assess the depth of crease, and scoring is again as we discussed for the medial crease. The empty heel sign is assessed by palpating the heel, trying to feel the calcaneum by the index finger as shown here in the figure. The 0 is when it is easily palpable and it gives you a feel of touching your chin. 0.5 is calcaneum is palpable with difficulty and you get a feeling like touching your tip of nose. And 1 is when it is very difficult to feel the calcaneum, or you can say the calcaneum is not palpable and you feel the sense of touching the base of the thumb from the palmar aspect. Next, the rigidity of equinus is assessed in an extended knee, trying to correct the equinus passively and look for the position of the foot obtained. 0 is when you can dorsiflex beyond plantigrade position. 0.5 is when the foot reaches the plantigrade but not beyond that. And 1 is when one is not able to reach even a plantigrade position. And the detailed score is charted on this Pirani score record sheet before starting the correction and at each successive visit. The scores can be also plotted to get this Pirani score graph, which helps in assessing the progress of correction. The other most commonly used classification is DiMaggio score, which is based on reducibility of 4 parameters and 4 complementary features. The reducibility of parameters can be assessed by manipulating the foot passively and observing the position of the foot obtained, and accordingly the score from 0 to 4 can be given. As shown here, the equinus is assessed in sagittal plane. Similarly, the heel varus is assessed in frontal plane. The internal rotation or supination is assessed in horizontal plane, and forefoot adduction is again in horizontal plane. The 4 complementary features includes posterior crease, medial crease, cavus, and deviant muscle function, that is any neurological issues, wasting, and each of these features carry 1 point each when present, so that the maximum total score can be up to 20, and then the deformity is graded into benign, moderate, severe and very severe categories. As discussed, I am not going in detail of the radiological assessment, but these are some of the radiological parameters which are very commonly used. The talocalcaneal angle in both AP and lateral views, and together they are used to calculate the talocalcaneal index, which should be more than 40 degrees in a normal foot. The other one is talo first metatarsal angle in AP view, and it has a normal value of 5 to 15 degrees. Thank you very much.
For queries, you can discuss while we will be discussing.
Yeah, we are changing over the laptop, so please ask questions. Please remember, questions cannot be wrong, only answers can be wrong. There is nothing like a wrong question. Any questions or yes? So good morning, friends. At the outset, I would like to thank Bihar Orthopedic Association for inviting me to their Golden Jubilee conference, and I am overwhelmed with the hospitality. So thank you, Dr. Nitesh, Dr. Amandeep, and team. So at the outset, I would ask you, how many of you are treating cluster? Please raise your hands. How many of you use Ponseti technique? So I'll be talking about the pathoanatomy of cluster and how it is relevant in the casting. If you see cluster, it's not an embryonic malformation. So that means developmentally the bones are normal, but it's a developmental malformation. That means something happens during the period of development where the bones they get malaligned. The good point is that this malaligned bones they can be corrected by gentle stretching maneuvers. So that's the crux of the entire thing. So overview of this presentation would be about the normal anatomy, the pathology in the soft tissues and the bones, and how it is relevant what it is. So if you see the normal anatomy of club foot, of the foot, to please remember 2 or 3 structures. You can see the tibia. Underneath that is the talus. That's the talus. This is the introitious talocalcaneal ligament. Very important structure for you to remember. Posterior to this is the posterior talocalcaneal articulation. Anterior to this are the 2 articulations, anterior and middle. The middle is over the sustentaculum talli. On the middle side, from this sustentaculum to the naviculus, inferiorly and inferior-medially, this is the spring ligament, and it actually supports the head of talus. And once this spring ligament is incompetent, this talus is going to drop down like this, leading to a flat foot. So, spring ligament, introitious talocalcaneal ligament, and posteriorly is the calcaneofibular ligament on the lateral side. Fourth is the deltoid ligament, which runs from the medial aspect of the medial malleus. The deep part in the talus is the superficial part in the calcaneum. So 4 ligaments. Introitious talocalcaneal, the spring, the calcaneofibular, and the deltoid. So what are the deforming forces like? The tibialis posterior tendon, the tendoacheus, and the plantar fascia and the associated muscles. What are the components of the deformity? We know cave, word cave. Cavus, adductus or adduction. Inversion, they are coupled together, and then is the coins. So cave, word, please remember. So what are the factors contributing to the cave? One is the first metatarsal drop. First metatarsal drop. And something like this. And if you have the first metatarsal drop, it is going to lead to cavus deformity. The second is pronation of the forefoot. Pronation of the forefoot. And if I pronate this forefoot, this is going to lead to increased cavus. And if I supinate, this is going to lead to reduction of cavus. So pronation of forefoot in relation to the hindfoot. And then are the soft tissues we have discussed. So how to correct this? The first thing is we lift the first metatarsal. Right? The second thing is you can see here, if I pronate the foot, the cavus increases, and if I supinate and lift the first metatarsal up, the cavus reduces. Well, it's not playing. Then is the adduction and the varus. They are coupled together, and in the adduction and varus, you remember two areas, rather three areas. The calcaneopedal block, that means the calcaneum, the cuboid, the rest of the tarsal bones and the metatarsals. They form a single unit. The talus forms another unit, and then is the subtalar joint complex, which is shown here in the form of this cartilage. This is the posterior articulation, oblique, middle, anterior, middle, and that's the navicular. So this is the subtalar joint complex between the talus and the rest of the bones. And functionally, all these bones, the calcaneum and the rest of the bones, they move as a single unit around the talus. And with this interosseous ligament as a center of rotation. Where is the interosseous ligament? Somewhere here in the sinus tarsi region. Right? So this forms a center of rotation along which the calcaneopedal block will rotate medially or laterally. So two functional areas of the subtalar joint complex, the posterior talocalcaneus articulation and the rest of the articulation, which is called the acetabulum pedis. This entire thing is the acetabulum pedis. So sort of forms a cup with the head of talus and the rest of the articulations anteriorly as the head sort of structure. And this red dot is the interosseous talocalcaneal ligament, along which all these structures will move this way or that way. Okay. So if you see this joint, this is an oblique joint. And this oblique joint means that you cannot have motion in one plane like this or like this. It is oblique. And this obliquity leads to a condition called kinematic coupling. So that means if I adduct the foot, my heel goes into varus. You can see it there. And if I abduct the foot, the heel goes into valgus. So that means the heel everts also, abducts and sort of dorsiflexes also. You can try it on yourself. So this is a kinematic coupling. Where it is happening? At the subtalar joint complex. So the clinical relevance of this is that the abduction of the forefoot causes external rotation of the calcaneopedal block with pivot or fulcrum at the interosseous talocalcaneal ligament. And the entire foot, including the calcaneum, everts, dorsiflexes and externally rotates underneath the talus. So I'll show it in a video, and I think I can pass out this model to you for you to understand the pathomechanism. So what are the factors contributing to adduction? The adduction, marsuplexion and inversion at the calcaneopubic block on the talus. Primarily the adduction occurs at the talonavicular joint. We have discussed this. The tight spring ligament again contributes to non-reducibility. Right? Calcaneofibular ligament, because if you see, the talus has to move away. The talus has to move away from the posterior end of talus. Has to move away from the calcaneum, from the fibula. So if this ligament is tight, this is not going to allow the correction. And third is the deltoid ligament, which will sort of contribute to inversion. So what is the basis of correction of adduction and release? If you see this, if you put a fulcrum on the head of talus, you abduct, see what is happening to the calcaneum. It is everting. So your hind foot inversion corrects if you abduct the foot with the fulcrum at the head of talus. Right? Simultaneously, what is happening? If I abduct, the forefoot adduction is getting corrected. And third thing, what is happening is, if you notice this anterior end of calcaneum, it is getting dorsiflexed. Right? So you can appreciate the anterior end of calcaneum getting dorsiflexed. So what this maneuver does, stretch the calcaneofibular ligament, stretch the spring ligament and stretch the superficial ligament, and corrects the abnormal positioning of the foot bones to a normal position. But if you do a faulty maneuver by keeping the fulcrum a little below, see what is happening. The calcaneal motion is getting moved. So calcaneum and the rest of the bones are connected together. They move as a single unit. So the fulcrum has to be, see, the inversion is not getting corrected. Here, right? And if I put the fulcrum here, the calcaneum is not getting dorsiflexed. I'll pass off this model to you and you can appreciate that. The question is, what is the basis of stretch? It's as described by Ponseti. The collagen is wavy. That means it is wavy. And it, Ponseti calls it like a crimp. And you can gently stretch that crimp to its normal stretchable limit. So this elongation of crimp allows serial manipulation and casting. But if you do an excessive stretch, it is going to lead to tearing of the collagen fibers. And this, once the tearing occurs, then you have a stiff, painful foot. The good point with crimp is that it allows you stretching. The bad point with crimp is that it can reform subsequently with each stretching. Till what age? Till age of 4 years. And this age of 4 is the threshold where you continue with your foot abduction braces. The last is the coins. So what contributes to coins? Which joint? The tibial joint, tibio-talar joint, but this calcaneum also is plantar flex in relation to the talus. So what this maneuver does is dorsiflexes the calcaneum. So this part of the correction occurs as a single unit along with adduction, inversion and a bit of dorsiflexion of the calcaneum. So part of the equinus part, small part of equinus gets corrected like this. Okay. So this is the contribution of the calcaneum and that is the contribution to the talus. The big component is at the tibiotalar joint. And this maneuver, I have told you, corrects the dorsiflexes the anterior end of calcaneum. So the calcaneum which Dr. Ritesh was telling, the two bones they become parallel, now start becoming convergent anteriorly. Okay. The problem with tendo-Achilles is that it does not stretch. So you have to do some sort of surgical lengthening. The commonly done procedure is retinotomy. So basically, to summarize, cavus contributed by drop of first metatarsal, pronation. What you do with the first metatarsal, supinate. So you are aligning the forefoot to the hindfoot. Adduction and inversion and a bit of plantar flexion at the subtalar joint complex. You have to keep the fulcrum on the head of talus. The interosseous sternocalcaneal ligament is the pivot point. It abducts, the foot abducts, he reverts, and a bit of dorsiflexion at the talocalcaneal joint, and tendo-Achilles cannot stretch, requires surgical correction. And the basis of this stretching is the creep or the grip. Thank you. So till we are changing, I'll be happy to answer any questions. I think I can pass out this model. You can actually perform the maneuvers, and we have another model.
Yeah, this will be keeping on the table. You can do there also. We will be getting turns from the table also.
Good morning. Say loudly, good morning.
Good morning.
That's it. Extremely indebted to my friends in Bihar who at this young age of mine they thought it fit to call me and to participate in a clubfoot workshop where you had the stalwarts like Matthew and Gupta ji and everybody. This subject has been very, very close to me since I became a student in 1966, but I learned lots of things and changed my philosophy of treatment over the years. You all are doing clubfoot treatment for years together. You have now, most of you have switched over to Ponseti technique, there's no doubt about it. And just now you have seen the kinematics of the whole thing. And this is, I would say, rather a revision of what we are doing, what mistake we normally make, and how we can improve that. So the Ponseti technique has come over the years. Clubfoot is there for centuries and for centuries. There are a lot of things you can see in the history of the clubfoot. So when I was switching over from kite method to the Ponseti method, I thought it befitting to find out the original articles of the Ponseti and original article of kite. Kite was in America and Ponseti was from Spain, who has shifted to Iowa. There was a difference of 20 years between the two of them. But in those 20 years, lot of water has flown through the candies. So I said, let me check out what are the dissimilarities in the two papers. That's a very interesting thing, if you see that. In kite method, there was no mention of Gavus at all in his article. He always talked about his fulcrum on calcaneum cuboid joint. He has not mentioned the word supination and pronation of the foot. And there was no emphasis on supination. And he said that when the forefoot hangs in abduction and muscles pulls the foot out in abduction, then you do the dorsiflexion of the foot. He said you cut the plaster by using the plaster cutting saw. And he said you bring the baby hungry, cast removed, apply plaster shoe and feed him and then complete the plaster. And you know that what Ponseti said, you feed the child and then you remove the plaster. There was no mention of doing a tenotomy of the tendon Achilles. And he never believed in bracing. And he said, I do not want the brace maker and shoemaker to complete my unfinished work. So, whereas Ponseti made lot of emphasis on the abduction brace, about which the Matthew talked to him. And then there was a follow-up, and he did not talk about the pronator shoes and everything. So there was a basic 5 or 6 very important difference between the kite method and this thing. We all have been doing, but during the course of our treatment, we found that many of the patients were showing a high degree of recurrence. Why they were recurring, we did not know about it. We never talked about the lateral teething structures, about this thing, what is this. Other people talked about this thing. So in the conventional kite method, we were correcting the adduction, we are correcting the varus by pronating the foot, which has been very rightly just now shown to you, and then correcting the equina, and there was a leverage on calcaneum cuboid joint. Now, if you have a leverage on calcaneum cuboid joint, as has been clearly shown to you by the kinematic, you don't allow the calcaneum to get itself unlocked from the subtendon area, moving to the interosseous ligament, which is the center of rotation, and to go into an abduction, external rotation, thereby correcting the balance of the heel. Therefore, this was one of the biggest mistakes, this thing. But this method, obviously the kite method failed, and there was not a proper understanding of the functional anatomy, what is in the normal and what is in the clubfoot. So, Ponseti, who himself was doing all patients by the kite method. You also did it, we also did it, we also did it. But we just did it and stopped it. And we did not give our mind to it and thought to it. Ponseti was the man, he said, there's something wrong is going on. Why this foot is showing so much high recurrence rate, this thing? So he went on, he found a paper by Farabov, who was a French deaf anatomist. He found that paper. And on the basis of that, he started dissecting the loss of feet, both in normal and if you could get any child with the club foot, he started this thing. And he tried to understand what was the basic difference in the functional anatomy of these persons. And that was the result that he published his first work in 1948, he mentioned that. And his philosophy was not accepted. Anybody. His first paper in 1948, and I learned it only in year 2000. I started doing only Ponseti in year 2001. And I said, when I started doing Ponseti, I said, the best thing is to learn from the masters. So who could be the master? I didn't go to Iowa to do this thing. The Jose Martunde was in India, and I got an invitation for that workshop. I went there, and I told Jose to teach us and teach me how exactly the Ponseti technique has to be done. And that is from where the all models started coming, which you have just now seen that. So what were the stages as has been rightly told to you? Correct the cables, which is basically because the drop of the first metatarsal. And the forefoot is slightly pronated. Okay, so there is a deformity of cables which was never mentioned in the guide method. And then you do the forefoot adduction correction. You do the correction of the heel valve, and last of all, you do the correction of the equines. In other words, all the deformity you are correcting it simultaneously, except the equines deformity. Okay, that is the way how to do it. And after you have done the correction, you are going to put them into adduction state. So you raise the head of the first metatarsal as has been told to you, and then instead of pronating, you do the supination of it. Now, as you do this thing, what you are doing it, you are aligning the forefoot with the hind foot. Okay, the hind foot is supinated, it is in varus, and with this you are aligning the forefoot with the hind foot, and keep the foot supinated. That is the basic underlying thing in your whole correction process. Then you gradually go on abducting the forefoot. Gradually go on abducting, gradually go on abducting, gradually go on abducting. Your calcaneum is absolutely free. There is no pressure on the calcaneum. And as a result of this thing, the movements of all the you see, all the talar joints, they all move together. There is no such thing that there is a movement at talonavicular joint and there will not be a movement at calcaneocuboid joint. Or the navicular, which is now coming over the head of the talus, will obviously push the cuneiform on the lateral side, which will going to push the cuboid and thereby putting them into normal alignment position. So all the joints move together. That was a very important concept because you correct all the deformities simultaneously. Okay, and then at the last you correct the equinus deformity. This is what we have told you. Many of the younger, my PGs and some young people who started this doing Ponseti, they would say, sir, we have not understood, this is one pitfall which I felt, that you say the forefoot to be supinated and aligned with the hindfoot, and then it was not very properly understood. So this is what we have just now told you, that how you align the forefoot with the hindfoot. Then the most important part was that what Kite did was, his leverage was on at the calcaneocuboid area. So you were in fact pressing the calcaneum and not allowing it to get unlocked. What big contribution the Ponseti made. He said, just move your thumb 1 centimeter above and come to the lateral part of the head of the talus. Now, how do you palpate the lateral part of the head of the talus? Very simple. When you are teaching your student, feel the lateral malleolus and just remove your thumb ahead and you will find the most prominent part of the bone, which is the lateral part of the head of the talus. That's the most important. Now, once you have done this thing, you have to give them above the plaster, not below me. Change the plaster every week and do more abduction. About, in my own experience, I have personally in my private practice, before leaving beside with the medical college, 1,128 Ponseti plaster I have applied myself. In the medical college, जो बच्चा thesis करता है वो भी करता था, assistant भी करते थे. But here in private, I do it all myself. And then of course you have to give them an abduction sprint for 23 hours. And this is what we have been doing that you have to have your pressure at this area. Now what is the important pitfall is that if you have a chubby patient, there are a lot of chubby patients come, then you find it very difficult whether this exactly is the lateral part of the talus, and that mistake can take place. That's what you have to think about this thing. And this is what Ponseti, in his own book he has written, that the orthopedic surgeon, even in America, were so rigid about adopting to any new technique that it took me 40 years emphasizing them that please move your thumb 1 centimeter above. That is what all he wanted. And with great difficulty people adopted to this technique, and since then the whole concept has changed. Now, as we have just now told you, that it is just not one tarsal joint which moves there. So some people don't try to understand. They say, sir, the simultaneous and gradual lateral shift of the navicular, cuboid and calcaneum, sometimes they don't understand, unless and until they are told specifically on such a model and show them that look, this is what is happening. That all of them are moving together and they are aligning themselves. So this is what happens. That with this thing you are unlocking the calcaneum, which moves at the center of rotation at intraosseous ligament. So the heel moves into the from parallel to the neutral position. The calcaneum goes into abduction and external rotation, and that is a time when you can feel the anterior part of the calcaneum. And when you have felt that means the calcaneum has come in position, that is a time to correct the equinus, not before that. That's extremely important. So there are lots of pitfalls in the plastering. The most important is that you see getting the patient, because a lot of patients come from rural area, getting the patient every week, especially from the rural area, we finding it very problematic. This is हम नहीं आ सकते हैं, ये है, वो है. And why we are changing the plaster every week? There is a reason which has been just now told to you. Because in the collagen, which is called as the krill, in the terms of Ponseti, reappears every 5th day. Okay? So they need to be stretched. So you have done the stretching for 1 week, again it is because the collagens reappear at the 5th day that lots of people came with the idea of a fast Ponseti technique or a rapid Ponseti technique. And Allah Muhammad of Palestine, he is very fond of doing a rapid technique, but I don't think there is any added advantage to that. Okay? Another very big important thing that I found in a plaster is that the child is all the time kicking, and sometimes you find it difficult to keep manipulating and applying plaster. So I thought it may not be a bad idea to apply a plaster in which you stabilize the knee joint and leave the ankle and the foot separate, and once your knee has been stabilized, then you do the manipulation and then you apply the plaster, makes your life a little easier. You can see this thing, that how we apply the plaster, and then we will complete the plaster by all raising, maintaining the head of the metatarsal in proper position, maintaining the arches of the foot. This is how the plaster has been completed, and this thing. Now the last plaster, where you have done the correction of the equinus, otherwise manipulations. But in 90% of the cases, even in my own experience, you have to do it. It doesn't take time, it takes about 1 minute of the time. Your last plaster has to be for 3 to 4 weeks time. I feel that at times when you are putting the plaster in 3 to 4 weeks time, in 70 degrees of abduction, 20 degrees of this thing, and then this thing, sometimes they may go into an overcorrection that has to be taken care of this thing. We have already talked to you about that not means to be done, you get a very good correction. Some very important common errors we make while doing the Ponseti technique. One, we do the manipulation and sometimes we don't immobilize them. Instead of giving a above knee plaster, we give a low knee plaster. And we try to correct the equinus as early as possible, even before the calcaneum has been released. And we don't give a proper abduction brace, and even a good abduction brace is not available. And pronating the foot rather than supinating the foot, and you are trying to do the external rotation of the foot to correct the adduction while the calcaneum remains in parallel. That's very important. And of course, abducting it using a calcaneum cuboid joint as a lever, and to failure to obtain a full abduction, and attempt to obtain a perfect anatomical correction, which is not possible. Now, two important complications. Plaster sores, yes, we have seen, but some people have also reported that young people who are the new inexperienced, they get do a forceful manipulation and have caused a fracture of the metatarsal. Abduction spring is very, very important. There are lots of issues with this thing. Matthew will just now talk to you how it is to be applied and what are the pitfalls into the placing this thing. We have made some modification because we were finding it one thing is that in spite of everything, the child was keeping the heel raised and it was coming out of the brace. So we tried to make some modification, what we call as the erosion. Some more pitfalls. Now, the tendons of the tibialis anterior extensor oris longer extensor levels are medially displayed. How do we all address them? Calcaneocuboid joint is directed posteromedially. How do we correct it and make it to a normal position? And the recurrence on the valves of the hind foot can sometimes be difficult to treat. Ponseti method is not a panacea for orthogrammatic patients and for myelomeningocele patients. Okay. And another important thing is there's a lot of emphasis on the clinical correction of this patient where you get a good primate foot. But they are not anatomically reduced. And if you take the X-ray of this patient, the normal angles of the calvocalcaneal angles are not achieved. And we have done some work on this thing and we have found that those feet where the foot looks clinically okay, but radiologically if they are not okay, the chances of recurrence of the deformity are much higher in those patients where the foot has not been radiologically corrected. Well, my dear friends, you all are sitting here and I tell you from my own experience that in spite of all this what we have taught, it's a very easy method. It has got an excellent result. I have stopped doing surgery for years now, I don't do that. You can get correction within a 6 weeks to 2 months time. No major surgery is required and it is all supported by clinical, imaging and long-term follow-up. So keep doing consulting, very rewarding way of taking the patient. Thank you for your attention. Thank you so much. This is how we run the clubfoot clinic brochure which is given to all the patients. Thank you.
Thank you, sir.
Thanks.
You can ask any questions if you have any doubt about it.
If you can ask actually.
You can ask.
So I'm not very sure about how height was working because probably we have not seen or learned that. But in Sir's talk, he showed that there were 8 plasters for cavus correction followed by varus 8 and then so there were there 24 plasters being applied. Was it like that for the kite method?
Before 2001, when I switched it over to the Ponseti method, we were doing the kite method. The first time which really sincerely I started doing clubfoot was in a clubfoot clinic at All India Medical Institute where we used to get 30 to 40 patients every day. The only method of treatment was the kite method and we are giving them a below the plaster. Below the plaster. Nobody at that time emphasized you give it the body. Patient will keep coming in and I remember that having given sometimes 8 plasters, 10 plasters, went on and we were not very satisfied. And at that time the brace which used to be given was a dense strong spring, which was also not very effective. And nobody knew that why these patients are not getting corrected till we understood what mistakes we are making. Okay? So the younger generation will not know what the right method was. Okay? Because you all are been born and trained in Ponseti technique, which is the right thing. But just it was historical because the senior people all they are the right method. Okay?
So can I add on to this? So I'm talking of 1993 and 1994, when I had more hair on my head and they were all back. So fresh from my post-graduation, we were only taught about the price map. So we did the manipulation perhaps perfectly or imperfectly. Maybe a bit of it worked. Why? Because lot of times I may not have been keeping the fulcrum on the calculated coordination. Might have been just abducting the foot. Only thing which I learned was that almost close to 100% they went in for a surgical correction. It was a posterior major issue. Please, I realized two things.
Even after the class.
Even after the consent.
Oh yes.
So I realized there are two things which are not getting corrected. One is the equinus and other is the cavus. Right? These two things are almost always there, and at that point of time I was never able to understand why this is happening. As Neja told, I realized only when I started doing the concentric method in 2001 or so.
Why they were not getting?
Why they were not getting correct. And now
A lot of surgery was being done at that time. And if you go into the literature, the posterior during the standard procedure, there are many people who came with the different ideas of how to do a posterior, including Professor Mukhopadhyay. That procedure is called as a Patna procedure. He has his own method of doing correction. And even in spite of doing so many posterior we must have done in 100, still we are not very satisfied. They were very dirty, scarred, foot will be very stiff, they were very painful, they will not be able to walk. And then came the Simon's, this thing who came with this complete subtalar disease operation. With the Cincinnati approach. So we said, oh, that's a great thing. So we started doing Cincinnati approach. So we started making new incision. Because when I was in All India Medical Institute, and Bin Mehta, you know, the Mehta and the scoliosis, she was a lady from whom I learned lots of things. And one day I talked to her, I said, ma'am, there is something which is doing the correction of the foot, and something happened in the lateral side. That was the lateral deepening of the structure of the lateral side. And that is what the Simon talked about. And that is how the complete subtalar disease. What we ever move to the lateral side of this knee, go on this side. And then the rule of the introsseous when the Simon came. So we started doing cutting down introsseous. Quite a few complete subtalar disease.
Right method से कुछ तो फायदा तो होता ही होगा ऐसा।
फायदा था ना, जो विषय को कहीं को तो ठीक हो गए, लेकिन याद रखिए इवन पॉजिटिव मेथड चाहे काइट मेथड हो या पॉजिटिव 100% करेक्शन पॉजिटिव ही 100% करेक्शन पॉजिटिव भी नहीं देता है and not the they will be 95% okay, they will be 90% okay. ऐसे ही काइट वाले 70% ठीक होते थे, ऊपर जूता बना के हम चलाते रहते थे।
I think I agree. So one little thing which we should add is that sometimes you feel that the equinus is correcting up to neutral zero. And you keep on dorsiflexing. Sometimes the foot ends up in a little midfoot break because you are forcing the tarsal bones more dorsiflex. So it ends up in a little proper bottom situation. So once you have this situation, you have a doubt. I feel it is better to do it rather than sort of relying on that. And I have seen it myself. That some of the cases which I accepted as corrected, during the course of the bracing, it came with a little equinus during the course of bracing. And at that time, I did it cannot be casted it again. So your experience about this?
I would very much listen. You see the local bottom foot deformity that was taking place in two cases, it was basically because the two things. Because those clinics were basically given to the registrar, not to second secretary. So first year registrar आया, उसको बेचारे कुछ आइडिया ही नहीं है, और वो फोर्सफुली करेक्शन करता था, टॉर्शन करेक्शन करता था, सब नहीं आया, और जोर लगाया, तो उससे कई दफा लोकल बॉटम डिफॉर्मिटी प्रोड्यूस हो जाती थी, because they were all inexperienced surgeon. But gradually, doing any technique in a correct pattern, also if this thing results which are sometimes acceptable, if you do not. I always say one thing, that what is today the nightmare. I told these residents that, look, I want the child to have a plaster, the clubfoot, as soon as you find it out. So it is, one RSO was found. The lady had a representation of the foot was hanging had a clubfoot. He was applying the plaster to that. So it is as early as possible. The Ponseti gives you the best result when done up to the age of 2 years. Excellent. We have now started doing Ponseti in the older children, even 7 years, 9 years, and even many of us have not gone this. But it's a very long drawn period. But up to 2 years, if you if the child goes beyond 2, 3 years, then of course the other matters like chess and video and all those things get covered. But after 2 years, you should take the child and fantastic.
So can I, so I think your concern is very, very valid, that if the child comes on day one.
Yes.
So the foot, if you are able, if the foot is large enough for you to hold the foot and apply a reasonable plaster, and the skin is not very tender, so that you don't expect a skin maceration with your plaster. You can start on day one. Otherwise, you can wait till the foot grows a little bigger, maybe 1 week, 2 weeks down the line. And then once you are comfortable, usually I will not wait for more than 2 weeks. But then, having said that, my situation can be different from yours. I have a weekly clubfoot clinic. So if a child comes on, let's say Monday, I have a clubfoot clinic on Friday. I'll ask him to come on Friday. So 5 days are automatically gone. So it's a little different, but I mean, usually you will not wait for more than 2 weeks.
You see, I tell you here one thing. Professor Mukhopadhyay, who has probably the world record of treating about 5,000 lymphocytes by single time. All done by.
Now,
अभी उसको पूरा lecture है उसके ऊपर. Okay, चलिए. Thank you.
you can continue with the lecture, I think.
Thank you.
Yeah, thanks. I think, thank you so much. Several comments. I was waiting for my turn for the mic. When I was a first year postgraduate, my supervisor was Dr. Sita Gupta, and she was a prolific operator of clubfoot children that Kite recommended. Ponseti's method is completely different. It is a simultaneous correction. Workshop after workshop, students come to me, sir, पहले तो केवस करना है ना sir? No. Every manipulation starts with supination and then abduction. Everyone, not just the first one. Remember this. This is a common mistake. I see many children that come with the foot pronated because the first cast was in supination, subsequent one was only abduction, no supination. Every cast starts with supination and not pronation or not just abduction. Don't make that mistake. So that's the first thing. The second discussion on the timing. I agree with PA. There is no rigidity. I agree with Dr. Gupta, Dr. Taneja on the whole issue that we do not have to worry about time. But I have done a retrospective calculation. How long can you tell the parents to wait? A lot of issues. There is a stigma associated. You go to your clubfoot clinic, if there is a busy clinic, you will find invariably the mother-in-law is not there, it's the mother who is there. Of the Nani will come, mother is there, but in-law is not there. So there are a lot of family issues, there are a lot of stigma issues that will come. Time and again I ask, Nani hai Dadi ho? Invariably with Nani, because there is a stigma associated with the child born with clubfoot, and therefore it is the mother's responsibility. She's made the mistake of having a child born with clubfoot, therefore she has to take responsibility for correcting it. The Nani is now worried, she'll have problems, so they will be coming. So all those social issues are there. You have to understand the social dynamics and then work. There are traditions like in Haryana, there used to be, they're still there, many children come after 6 weeks. क्यों? कुआं पूजा होता है. कुआं पूजा 6 हफ्ते में होती है. उससे पहले माँ घर से नहीं निकलती. So there's the tradition the mother is not going to be brought to the clinic with the child until it's after Gua Puja. So if there is a tradition, respect tradition. That's okay. They may have a meaning, they may have wisdom, we do not know. So we allow them to go after 6, no issues. Sir, ला सकते हैं? देर तो नहीं हो जाएगी? No problem, you can bring after 6 weeks also. I have done a retrospective calculation. What does a mother need for the child? The mother needs that her baby will be a normal baby. A normal baby, look at the milestones. When does the child sit? 6 months. When does the child stand? 8 months. When does the child stand? Walk. With support 10 months, without support 11 months to 13 months. So, when the mother goes for vaccinations, when the mother goes to the clinics, it is important that the baby should have the ability to stand on his toes when he is ready, on his feet, when he is ready for standing like the other babies. He shouldn't be delayed. So, if the standing period is 8 months, by 8 months the child's feet should be normal without a brace. That's the protocol. Normal without a brace. So if you want to work back now, 3 weeks after tenotomy, that's 3 weeks, 5 or 6 casts, which means 3 plus 6, 9 weeks, which is a little over 2 months. Then there is 3 months, 23 hours a day, brace protocol, which means 5 months. So if you have a delay of anywhere from 6 weeks to 12 weeks, is still okay. The child will be able to stand at the normal time without a brace on his legs. Is it clear? So when we look at the results, it doesn't matter. They do very well. Most infants, if they come less than 6 months, they do very well. Don't worry. There is an argument for very early treatment, not the breech foot. When the first foot comes out, you start casting that. No, not that. That's a joke. But the argument for early correction is, in the newborn baby, the mother's relaxin ligament is circulating in the child's bloodstream, and therefore easy relaxation of the ligaments are there. That's the logic used by people in the Switzerland group. Teddy Stronger and all, they use that logic for very early correction. First week. Within a week you start correction because it's more stretchable. But remember, you may use more force then. You need to be very skilled in doing that whole technique. And while you're doing manipulation, you're stretching soft tissues, which are muscles. You're stretching ligaments, which are stretchable. What is not stretchable is the tendo-Achilles. And there comes the importance of Ponseti's method of tenotomy. Ponseti published his first article in 1963 JBJs. But no one noticed him, no one took on the article's content seriously. Nobody followed him. Whereas Samuel Turco, Greek surgeon working in UK, his technique was immediately taken on. The Americans do not respect anything done in the Europe. They don't. They have to be something their own American. Uncle Sam's technique has to be different. So they have their own Cincinnati method. So everybody in the US followed Cincinnati method, everybody in Europe followed a European British method of Samuel Turco, and India followed the British, the Turco's method. So when I was a first year PG, when I was doing Kite's method, my second year PG had a thesis on early Turco's method for correction of cluster. Early Turco's method. And when I did those, I learned and I was very good at it. I could lay off the foot and put it back. I can still do it. But when you follow them up over a period of time, 5 years down the line, then you realize every tissue in the body heals by scar tissue. Except bone. Except bone. Bone heals by forming bone. Every other tissue heals by forming scar tissue. And the characteristic feature of a scar tissue is it is inelastic. It doesn't keep pace with the growth of your bones. Because the inelasticity of the collagen of your scar tissue, you have recurrence because skeletal growth continues, soft tissue, scar tissue growth does not keep pace, and therefore the need for long-term follow-up even in Kite's method. Remember that. There is a possibility. So what did Ponseti say? Is the recurrence rate nil? No. The first year recurrence rate of the master himself was how much? 49% was his recurrence rate. 49% was his recurrence rate. It was not nil, no. In the master's hand. After the non it was 49%. Till his fellows followed up case and found that those parents who were worried about recurrence and continued the breasts, their feet were corrected better and longer term. So the priest protocol got increased from 6 months to 1 year to 2 years to 3 years to 4 years. So is the recurrence rate nil at 4 years? No. It is still about 15%. Then it went up to 5 years. Is the recurrence rate nil at 5 years? No. It is still 6%. You still have a higher recurrence rate. So you need to look at the foot and then take a call. Is there dynamic supination? Is there any residual deformity? Is the equinus good or not? And then take a call. And the equinus part, the toughest tendon, so you have the phrase Achilles heel from Greek mythology. Achilles heel gives the impression the weakest spot of a person is the Achilles heel. When you say that is his Achilles heel. His overarm bowling is not great, but his other techniques are good. So his overarm bowling for a cricketer, that's his Achilles heel. That is his weak point. So when you want to describe a weak point, it's Achilles heel. But technically, for a human being, the tendoachilles is the toughest tendon in the body. No other tendon comes anywhere close to its thickness. It is the toughest structure. So when you are stretching ligaments, it cannot compete with the toughest structure with the tendoachilles, and therefore, if you try to do manipulative correction of equinus, which is caused by a tendoachilles, you will end up with a rocker bottom foot. A rocker bottom foot. And once you have a rocker bottom foot, you will never forget it. That rocker bottom foot, as Dr. P.N. said, that it is a mid-foot break. So when I use the term sometimes in the clinic, I am very careful. Doctor Sahab, fracture ho gaya kya? Break means a fracture in their minds. Here it is a break of the ligaments in the metatarsal joint. And therefore there is a rocker bottom that comes up, head of the talus moves from the normal relationship. In a clubfoot child, there is parallelism in the lateral talocalcaneal angle. As you correct it, this parallelism becomes better to have an angle anywhere from 25 degrees to around 50 degrees or so. This is a normal lateral talocalcaneal angle. Why is there such a wide variation? Depends on the position in which the X-ray is taken, whether it is dorsiflex position or plantar flex or mid-foot position. That tells you where the child's talocalcaneal angle is, whether it is normal or abnormal. So when you want to do an X-ray, there is no need for doing X-rays in Ponseti's management of it. We do not recommend it. We do not recommend X-rays in under 6 months children anyway. As far as possible, that's why you have sonography for DDH evaluation. It's so much simpler to do an X-ray in a child. We do not do that. We do sonography. Why? Because they found that long term many of these children, when you follow them, there is exposure to ionizing radiation. In the less than 6 month period, there is a higher chance of having leukemias. So that's anecdotal, hard population research, I do not know, but there are episodes which are described there. So we do not want to take that chance, we do not want X-rays in children, and there is article on this, those who are literature minded, evidence based minded, based on peer reviewed literature. There is an article in JBJS, is there a role for routine X-rays in clubfoot children? The answer conclusion in that paper was very emphatically no. There is no role for routine X-rays in these children. So you need to understand the dynamics of when do you want it. You would want an X-ray if you ended up with this rocker bottom. If you have a midfoot break, that means your technique is faulty, therefore you got a midfoot break. We don't want this to happen, we want to prevent this. And to prevent this, the tenotomy rate in a child is more than 90% in an idiopathic clubfoot. More than 90%. If your tenotomy rate in your clinic is lower, the chances are you're compromising somewhere. Chances are in your clinic, follow 5 years down the line, you may not be there in that medical college. Your junior will then see his recurrence rate is higher. The recurrence rate will be higher. So you need to be very clear that the tenotomy rate in a good clinic with good concentrated method following will have a very high tenotomy rate, as high as 90%. So the indication for tenotomy is when the hind foot score is more than 1 and the midfoot score is less than 1. Why didn't we say 0? We said midfoot score is less than 1. Why not 0? We aim for 0 because many of these children, the midfoot score comprises of 3 things. 1, the medial crease. 2, the curved lateral border. 3, the talar head. Talar head has to be 0. If the midfoot score shows a talar head of 0.5, it is not ready for tenotomy. No. It has to be a score of 0. The curved lateral border has to be a score of 0. The only point where it doesn't become 0 is the medial crease. It doesn't become 0 in all children. And therefore you may have a situation where a child has a score of 0.5 but is ready for a tenotomy. Understood? Again, hind foot score is more than 1. Why didn't we say 0.5? Because many of these children who have rigid equinus score of 0 with posterior crease score of 0 have an empty heel which is not 0, which may be 0.5. Okay, so the empty heel doesn't feel, if it is 1, it will be soft like this, thinner eminence. If it is 0.5, it will be firm like the tip of the nose. If it is hard like this, that's a score of 0. So many of them are not hard like this, they are midway there, and therefore it is 0.5, and therefore it has to be more than 1. Is it clear? So your scoring will tell you that the child is ready for tenotomy. So if the score is like this, will you still do a tenotomy? No. You're still not ready for a tenotomy. You may get this level by 4th cast. You may get a midfoot score of more than 1 by 4th cast, and a hindfoot score of less than 1 by 4th cast, and a hindfoot score of more than 1 by 4th cast. Will you do a tenotomy? No. Why? Why would you do a tenotomy? Because model had failed. Somebody had that model. Why wouldn't you do a tenotomy? Because this curved lateral border has become 0, talar head has reduced, that's 0, but the abduction is not sufficient. In a newborn baby, I can stand here. In a newborn baby, the abduction has to be wide. 70 degree after tenotomy, before tenotomy at least 30 to 40 degrees. So unless you got abduction, so many children, I go for workshop, they tell me, sir, ये तो ready है tenotomy के लिए. मैंने कहा मतलब चल नहीं ready नहीं. Sir क्यों नहीं ready? Sir आप तो बताते थे midfoot score less than 1, hindfoot score more than 1, ready है. So then I say no, the midfoot score is less than 1, but the foot abduction is 0 degrees or just 10 degrees. I need to have a reasonable degree of foot abduction. Why? Because unless you achieve good foot abduction, the hind foot varus does not complete correctly. And if you do an early tenotomy, the hind foot varus will refuse to get corrected, and that will cause early recurrence because of early persistence of hind foot varus. So do not do your tenotomy too early. You will end up with a slight hind foot recurrence, and the best way to check for hind foot recurrence is tell the mother to hold the baby like that with the hind foot visible. You can clearly see the hind foot varus really. You can never make it out from the front of the child. सामने से देखते हैं हम, पीछे से नहीं देखते हैं. पीछे से नहीं देखते हैं तो hind foot नहीं दिखता है. Hind foot नहीं दिखता है तो varus नहीं पता चलता है. And you leave a residual hind foot varus and you do a tenotomy. Everything looks good. Parent बड़ा अच्छा हो गया. उल्टा पैर था अच्छा हो गया. नहीं अच्छा नहीं हुआ. You've done a mistake there. Abduction was not sufficient enough to allow tenotomy. Get that right. You need to have that right. So what do? Under local. The first time I did tenotomy, under local somebody told me you're doing child abuse. No. I kept doing them under general anesthesia because I never learned from any workshop. In fact, one of the clinics, one total upper class patient come to me. The child was nicely getting corrected. Very nice, by 6th class, almost ready for tenotomy. So I told the child needs. So that day, the grandmother of the child was there, very society lady came in. Sir, are you trained by Iowa Ignacio Ponseti? I had not been. I was self-taught. I had been fortunate to be taught by Shafiq Pirani in year 2000 in a workshop. Beyond that, nothing. I had no workshop certification. So I made a point, I'll go and get a certificate from Iowa City. And I did do a workshop there and I can have a certificate, but I didn't have a certificate at that time when that lady asked me. The first time I was challenged. Sir, do you have a certificate? They didn't get that, cannot be done from me. Put correct ho gaya tha. They went to Iowa and got it not me from there. They researched me for that. I'm talking about early 2000. They were total upper class anyway. So I used to do GA tenotomies before this. Till the first child who had GA for tenotomy, I went to the other side to do some other surgery. Plaster तो लगा दिया, अब तो आउट ही करना, उधर चला गया. वो खत्म करके वापस आया तो चाइल्ड हॉस्पिटल में GA क्या हो गया? सर रिवर्सल नहीं हो रहा. Reversal नहीं हो रहा. Some problem of anesthesia, child was not getting reversed. So I had to really have a tough time explaining to the parents. Child went on a ventilator, 12 hours remained on the ventilator, अगले दिन extubate करा. After that I've never done under general anesthesia. Always under local anesthesia, that's all that you need. Xylocaine, plain, not with adrenaline. Number 15 blade, and that's it. Povidone iodine solution, xylocaine, number 15 blade, Bart Parker blade handle of number 15, gloves, assistant has to be there, who holds the foot in maximum extension. Clean, I don't do any draping now, I just clean. In my OPD I do it, earlier I used to do it in the theatre, in my OPD. Regular OPD, there is a dressing room, reserved, morning, all fresh linen, we use that. Keep the knee as straight as possible, stretch the ligament as much as possible, hold it stable, not prone, lateral position, not prone, because prone you will push your knife into your neurovascular bundle, you don't want that. It's only the lateral position. Local anesthetic. The question is, where will you put the local anesthetic? The common mistake is doing the local anesthetic. Putting too much, too little, too low or too high. Let's look at the logic behind that. So, a lot of problems in identifying the tendoachilles. You will find it. It is more lateral than what you think it to be. It is not as medial as you think it to be. It is more lateral. And then, when you stretch the skin, there's a little depression that comes there. Even in the chubbiest of children, when I told this to Dr. Shafiq Pirani, he said, "Nee, chubby children mein nahi hota." So there was a chubby child right there. I said, "Ye dekho sir." In chubby children also this depression is there. That's a short identification of your tendoachilles. People are worried that your tendoachilles is so close to the neurovascular bundle. You have to know your surface anatomy. What is the surface anatomy? Your medial malleolus is there. Okay? Your tendoachilles is there. The surface anatomy of the neurovascular bundle is midway between the medial malleolus and the tendoachilles. Midway. Bang in the middle. The neurovascular bundle is in a different facial compartment. The tendoachilles is in a different paratenon. They are in totally different compartments. So you have to understand that. Then you can recognize a tendon by just stretching it. And where to do the tenotomy? The book says, and Ponseti himself says, do it 1 centimeter above the heel. There you look at the tendoachilles. This is a normal shape of a normal child with tendoachilles. That's broad, narrow, and then broad again. If you do it close to porosity, within a centimeter it is broad. Your probability of doing an incomplete tendoachilles tenotomy is very high. If you do it very high, again it's broad, your probability of doing an incomplete tenotomy is very high. An incomplete tenotomy means incomplete equinus correction, and incomplete equinus correction means recurrence. We do not want that. We want a complete transaction and in the safest zone. I was at Manchester for a session on tenotomy. Somebody else was taking the lecture and she knew complications of tenotomy. I said, oh my God, I have done over 8,000 tenotomies in my clinic, over 8,000. And I have not had a single child with incompetence or a calcaneal problem. They showed 2 X-rays with the calcaneum divided from there. The child must have kicked and the knife must have cut through the cartilage. It cuts very easily like soft tissue. Cartilage cuts it doesn't heal. Cartilage is avascular, anervous, it doesn't heal. So that is why the direction of the blade is never plantar side, it is always upside. Even if the child kicks, you don't cut the cartilage. Soft tissues heal, albeit with scarring. Cartilage doesn't heal, you have an incompetent endothelium. You don't want that. So therefore, the blade always has to be face cephalic and the level has to be the narrowest portion, and in a normal human being it is at the level of the middle malleolus. At the level of the middle malleolus. Okay? But when the child has the equinus, this is a little higher. So my level for tenotomy is not based on the tuberosity of the calcaneum. It is based on the medial malleolus and going a little higher in an equinus deformity of the child. There you hit the narrowest portion, there you hit the sure shot tenotomy, and there you hit the narrowest portion of the tendon, and therefore a complete transaction and success is possible. Rest is straightforward, you cut it. And that's where you just insert the blade. That's the text, original text, that's an original slide that I have from Norgo Penny, which says 1 centimeter. I follow the regime that I talked to you about. An audible pop will come. So what do? You put in your blade in that area, the cutting edge facing cephalically, and turn it first parallel to the tendon, between the tendon and the middle malleolus, and then turn it around 90 degrees, and you don't do a seesaw movement. You just press your finger against the tendon. It cuts, it's a tough structure which cuts very easily on pressure. You just cut it against that and it will then clearly do a pop. Apply a thin gauze or sometime wait. Do not be in a hurry to put a plaster. You may end up with a soaked plaster in blood. I have seen that. Completely soaked because you didn't have the patience to wait. Do I do BTCT? BTCT is irrelevant anyway. It doesn't tell you anything. So it's no longer, there's no evidence of doing BTCT in these children. If at all you have to do, you have to PTA, PGT. Do I do it? I don't do it. Have I seen hemophilia patients? Yes, I have 2. In my more than, I think it's 8,500 now, more than 8,500 tenotomies, I have seen 2 hemophilia kids, male children, and usually they will give a history of bleeding problem. Umbilical stump or somewhere there will be some bleeding. They will come with that. You don't get that history right in the first time itself. Is there any bleeding history? But do not worry about doing a PTT, a PT, and PTT in these children. We do it and do the tenotomy. Keep it. What do? I have 4 or 5 children for tenotomy on a given day. Do the tenotomy, put a bandage, wait. Do a tenotomy, put a bandage, wait. Do a tenotomy, put a bandage, then one by one get them back for casting. And by then it's about 15-20 minutes. Even in the worst case of bleeding profile which is there, it usually settles. And all is good, and there is no soakage in the plaster, it's all good. That's the video to show you. See that? Can you see the depression? So I am doing the local anesthetic. That's the medial malleolus, that's the depression which is the tendinoachilles. I do the local anesthetic injection there and take it out. Keep pressing, wait for 1 minute, have patience. If you do not wait, the child will howl. I have patients, students coming to me, sir, एक prick दे रहा बच्चा रोता है उससे मगर उसके नहीं कर सकते हैं. No, I don't think that is right. Child will have pain unnecessarily. Number 1. Number 2, you may do an incomplete job. Number 3, pressure to prevent bleeding subsequently may be painful for the child. So anyway, we don't want that. So I wait. I massage it nicely so that the local infiltrate spreads well. Then, there. Can you see the depression? That's the depression. That's the depression of the tendinoachilles. Take the blade. You can see the small puncture of my needle. The cutting edge of the blade is cephalic. I push it in. I push it in, turn the blade, 90 degree, done. 4 seconds में मिलेगी. It's done. Look at the dorsiflexion that is there. It is so simple. But कुछ पता चला आपको कि क्या हुआ नहीं पता चला ना? Let's look at it in an older child in a slow motion. Watch this now. See, that's the tendinous, narrowest portion, that's the middle malleus, little below. Cutting it this way, turn it around 90 degree. Yeah. Now the sharp edge is against the tendon. Keep pushing this. I'll keep pushing this. I'm pushing. Again I'm pushing. So as the blade comes superficial to the skin, I'm scared I'll cut my hand. And therefore I'll be putting less. It's just about to happen. There. Done? You see the dorsiflexion. See there is a gap that has come up. That's a 5-year-old boy. That's a 5-year-old boy I'm doing a tenotomy on. There. You have a good gap, good dorsiflexion has to be achieved and you're ready for your final cast post-tenotomy. In older patients, I give immobilization not for 3 weeks, but anywhere from 5 to 6 weeks depending on the age. No reported, actually the incompetence. One child whom I operated, I was sure I had a pop, it was corrected, but I couldn't get the correction. Equinus was not getting corrected. So I posted the child, can I open up now? No. I've done a transaction, so I can't open up then. How does the tendon regenerate? Because the sheath is intact. So students come to, sir, आपने तो पूरा काटा ना, sheath identify तो करा नहीं है, तो ये तो आपने पूरा sheath भी काट दिया. How does the sheath is intact? The tendon slides inside the sheath. The sheath is attached to the surrounding tissue and it doesn't slide. Tendon slides, the sheath is there. And with that small puncture, your hematoma within the sheath causes the regeneration of the tendon and therefore it works. And so here we have a child in whom I was sure I've done it. I waited for 5 weeks, went back and did an open. I found an accessory soleus was there. It is reported in literature, but the tendon itself had regenerated completely. It's a full thickness regenerate. It's not a partial thickness regenerate that you have in this patient. So that's a 12-year-old boy in whom I am doing a tenotomy. To those of you who want to find out what is the upper age group, there is no upper age group. I have done it at 36 years also. That's the same boy whom I have done. It's a full video, I don't want to show it. It's just the same thing repeated. That's a 23-year-old girl in whom I have done it. Earlier I used to take 11 number blade in older children, now I do only 15 number. Because sometimes if the foot moves a little bit, the sharp edge can poke through the other side. I don't like that. So, you do not have a pop in older children, you do not have a pop in redo tenotomies, you have only a slight increase in dorsiflexion, full increase does not happen. So what do? Call them after a week for redo dorsiflexion cast. Now, you can do dorsiflexion without fear of rocker bottom. Why? Because the tougher tendon is gone. Now you can do dorsiflexion. Now it's easy. Now you don't have risk of rocker bottom. So see the gap that is there? There. You can feel with the tendon the depression that is there. Almost a centimeter gap sometimes. It gets filled up. So people say, when I first told it to an American, are you kidding? That was, he looked at me and said, you're kidding. I said, no sir, you have 5 minutes, I'll show you a video. I showed him this video. Oh my God, I'll have to go back and redo my cases. That's the tenotomy, the same girl whom I showed the video on. 23-year-old girl, tenotomy, corrected by Ponseti casting, came with a recurrence, did a tenotomy at this age. 6 months down the line, she can walk tiptoe. You can't do tiptoe walking in 2 months, 3 months also. It will take 6 months. Warn them on that. Thank you.
Thank you, sir. Now we will be moving to.
Can I just add a comment on? So one is that there's a little trick which I learned over a period of time. Is that what you do is, since you have a busy clinic, Dr. Matthew has a very busy clinic. So what I do is put on gloves, clean the area, inject local, and then change the gloves, drape the patient. So it takes about a minute, and that minute will be sufficient for the local to actually take effect. So this is a little trick which
You
I
need
learned.
to have time.
So,
That's a
yeah.
very good.
So-
I don't drape, I do it without draping.
Yeah, even I don't drape. Draping means cleaning,
Ah.
cleaning of the foot with polyethylene iodine. Initially what I do is take a spirit swab like you give an IM injection, clean it, inject a local, and then you start cleaning the foot for sort of anatomy. Put in a drape just below so that the foot doesn't touch. Just a simple one single drape. The second practical problem which sometimes I have faced is that when you inject local, your side of local is, you don't raise a big V there. Could cause a swelling there. You lose that side of local. So you have to mark it a little. Either it will be a bleeding point of the bleeding or just mark it a little. So you have to remember where you have to go. This is sometimes so always fine with like this. Fine like this.
Any questions? You're welcome. Like Dr. Kian said, there are no wrong questions, only wrong answers.
Yeah, please come forward actually. So,
Now we will be discussing this bone model maneuver on the table. You can ask the question directly with sir also, there also. Yes, Dr. Amar.
So without local we cannot do anatomy. Or if you are doing a local, if you are putting the local injection, they are difficult to locate the exact tendon where we want to cut the tendon.
We can, that's why I showed you the technique. You press, don't put too much of local. Half an ml for one infant is sufficient. You don't need to put. Only time we need to put extra local is in a redo tenotomy. There you may need to put behind, below, inside also sometimes because nerve ingrowth happens. So there you might do. Otherwise, only half an ml is sufficient. And if you notice, I kept pressing till I could get the depression back. Once you have the depression, you know the side of the tendon. There is no problem in identifying the tendon. I always do it with local only. Many of places people have come to me. We can do it. I do it without. I can do it, but I think it's kinder on the child to do it with the local.
Have you encountered with the hypersensitivity with gyrochem?
Never. I've told you I've done over 8,500.
I've done maybe, in my hospital, more than 1,500. Never encountered.
There are many papers about doing that in order using the 16-gauge needle. And we have also started using that about 16 or 18-gauge needles. So what's your take?
Yeah. So needle tenotomy is one technique which is there. Some people are very fond of it and are very skilled at it. I've not really had the heart to try it because the beveled edge, cutting edge of the needle is not as wide as the width of the tendon in a child. And therefore, you will have to stroke it back and forth. There you might make a mistake. But if you are doing, if you are skilled, happy doing it, go ahead, do it, no problem. The idea is to cut the tendon, make sure you cut it completely. That's all. The Pune group, all of them do needle tenotomies. All of them do needle tenotomies.
I mean,
The master himself did only with an ophthalmic blade, not even a needle, not a number 15. I have tried getting an ophthalmic blade, but they also don't have it. So I told them to manufacture it, but they are not willing to do it for somebody like me.
I don't think because I tried once. It's very difficult to do for me because you don't see what
You
the
need to
child
do
has.
stroking. You need to
use
stroke.
multiple strokes of the. So child will struggle during that period. It's a little discomfort to the child. I will not say.
All those we
painful.
saw, they were all under local only. So
What Dr. Sandeep Patwardhan is in
always
GA.
needle. He does always needle, I know it.
GA is
Came
different.
here.
So that is why I think he's doing in GA. That is why it's more comfortable.
Yes, sir.
It doesn't make GA, I don't know that.
But now sir said that he has stopped using local. Directly
It's
puts the
still
bit
trying,
on.
actually.
Yes.
I will not say something is right or something is wrong.
How you are getting it fine with the patient?
What is your setup?
Yes.
How much well you can afford it?
If I am teaching, I'll teach the blade, surgical blade with local anesthesia only. Once you are a master, you can do anything. Feel free. But complete tenotomy, complete transaction, not incomplete.
Do you use in some anytime like pedichloral or phenargin for casting also?
Never.
Like
I never
very
use anything.
irritable child,
Never
especially after 1 month when they start kicking and what.
You can come and see what I do. I have videos of my clinic. Nothing. No sedative at all. Child is fed, comfortable, is playing. I have toys in my clinic. I have iPads showing cartoon films to them. They are happily watching and doing this.
So two things you can do. One
Use
is
your
you ask.
parents know.
Yeah, parents should usually show them a phone with some video of their liking. Most of the time, this is the trick which I do with my
Now we will start with the casting. How many of you have applied the plaster in CTV patient? Direct. With your hand. Most. And how many of you have not applied in CTV patient? Never. Okay. So today you will get chance to apply plaster on the rubber model, and the masters will be with you to guide you. So I request Matthew Varghese sir, there is a bone model. So first it will be demonstrated the maneuver technique of foot, how to maneuver, and after that you will have a rubber model on which you can apply the soft roll first, followed by plaster, and under the guidance of master. So I request Dr. Ritesh Pandey and Dr. Shashi Khan will be with Matthew Varghese sir, Dr. Jasminda and Dr. Saurabh Chaudhary will be with Dr. P.M. Gupta sir.
Landmark for him to put the cotton is till my thumb. Okay? The foot hasn't moved from where it was. Okay? Chalo, chalo. Is it clear? नहीं दिख पोज बना रहे हैं ठीक है मैं ग्लव्स नहीं डालता हूँ पीपल वेयर ग्लव्स दैट्स ओके आई डू इट विदाउट ग्लव्स वापस जाइएगा कीप स्मूथनिंग इट अच्छी तरह से स्मूथन करे जाओ और एंड तक जाओ जल्दी यू हैव टू मूव फास्ट आई डोंट नो सेटिंग टाइम क्या है इसका एंड तक ट्विस्ट करो हाँ गुड वहाँ पे ट्विस्ट करो गुड गो बैक नाउ गो बैक कीप गोइंग बैक हाँ ऊपर नहीं कॉटन के ऊपर मत जाओ एंड एम टू फिनिश द प्लास्टर ऑन द लेग इटसेल्फ आपने एक ही जगह रिपीट कर लिया ऐसा नहीं होना चाहिए ठीक है उसको हाँ, वापस ले जाओ ऐसा नहीं है एटलीस्ट ये इस इन्फेंट में 1/2 रोल इज सफिशिएंट एंड वाले एंड ऑफ द प्लास्टर निकालो आप गेट द एंड ऑफ द प्लास्टर आउट ये लेग पे ले जाओ बम्प करके रखो फुट पे नहीं लेग पे ले आओ बम्प करके रखो नाउ हिज जॉब इज ओवर नाउ आई टेक ओवर get my thumb to the head of the lens which was there get my index finger to this now I am smoothing this आपने ठीक से नहीं करा I have to mold all around the lateral malleolus mold around the heel index to thumb thumb to index I do molding one hand holds the other hand molds I have to get the shape of the lateral malleolus to get the shape of the heel, get the shape of the middle malleolus, index to thumb. At the same time, I make sure I don't leave a pit. At no time do I touch the calcaneum. Index to thumb, thumb to index. Now you know understands the importance of doing this. Index to thumb, thumb to index. Keep molding, keep holding, keep molding. Index to thumb, thumb to index. Index to thumb, thumb to index. Keep molding and keep holding. Keep molding and keep holding. Till the plaster sets. You have to move fast. Index to thumb, thumb to index. It's almost set. So see this. This is the position. This is on the first ray. This is on the head of talus. I move my thumb away, bring my finger in. But the thumb doesn't get lifted until the finger is in place. It's like a high security prison. एक गार्ड जब तक दूसरा रिप्लेसमेंट नहीं आता हिलता नहीं अपनी जगह से हाँ तो ये जो है इंडेक्स फिंगर हटेगा नहीं जब तक थंब नहीं पहुंचेगा, ठीक है? इंडेक्स टू थंब, थंब टू इंडेक्स. सो यू हैव टू बी एम्बीडेक्स्ट्रस, डेक्स्ट्रस विद बोथ योर हैंड्स. सेट हो गया वैसे, बट मैं सिखाने के लिए सिखा रहा था. हैव यू अंडरस्टूड? नाउ यू लुक एट द कास्ट. ओके, it has to be right till the toes. Can you see this? Right till the toes. Now see, chodo. Can you make out the heel? Shape of the heel? Yes. Can you make out the shape of the middle malleolus? Yes. Can you make out the shape of the lateral malleolus? Yes. That is a good cast. Where at the end of your casting, you should be able to make out the shape of the heel. So this cast will not slip. A cast that is loose, a cast that is not well molded will slip. We don't want that. So we want a well molded cast will not slip. A snug fitting cast will not slip. Understood? So now, why do we leave this bump? We leave this bump because when the child comes back for cast removal, we do not use plastic cutting saw. I never use a plastic cutting saw for children. They all have basins. इसमें कि गुनगुना गर्म पानी रखता है, बच्चे को पानी के अंदर डाल दिया जाता है, प्लास्टर गीला करते हैं, 10 मिनट में वो खेलता है पानी में. He is happily playing in water. Both parents are there. And then I unroll it. गीला होने के बाद it just unrolls. So if you have a bump left there, you know the end of the plaster, you pick it up and unroll it. Supination and a little abduction. दोनों करा ना मैंने. So again, तुमने ध्यान से नहीं देखा, मैं दोबारा रिपीट करता हूँ. So I take it out, no bleed. So this rubber model is like a child. We don't want any cuts on it. निकाल दिया. See this. So that's why I said the first cast is in supination and abduction. The second is also supination and abduction. The third is also supination. Every cast is a supination and abduction. And it is not a sequential correction, it is a simultaneous correction. Abducting a supinated forefoot. Okay, so here I do this, go there. My middle finger is on the plantar surface of the foot. See this. And it is supinating. This is taught to me by Shafiq Pirani. And the index finger is on the first ray. There. Abducting. ठीक है. So I asked him, sir, कितना pressure लगाएंगे? He said, come here. Put out your hand. So I put out my hand. Sorry. Trying to avoid a wet hand to touch him, but he will gila you. Anyway, so put out your hand. So your thumb, leave it relaxed. Okay. So assuming this is a foot, I have to supinate and abduct. Supinate and abduct. हो गया? That's all. There's no force. If I use force, you will wince. You might hit me also. थोड़ा जोर ज़्यादा लगा दे तो you might come and hit me. So you don't use force. It's a gentle supination and a gentle abduction, and you're done. And there's no force. The child doesn't cry.
Time of manipulation.
Hey?
Time for manipulation.
Time for some people say you should do it 4 or 5 times. Do I do it? No, I don't do it. I just go position it and cast it.
After manipulation and plaster, is there any time?
After manipulation and casting?
बीच में कोई टाइम इंटरवल है?
Yeah. So there have been researchers looking at child having the cast removed at home and then coming to the clinic, and child having the cast done immediately after the cast was removed. They found that children who had cast removed at home took an average of at least 3 casts more. So it's best to remove it in the clinic and not at home. Just before casting, that is what is recommended. Okay? And once you have done the manipulation and casting, it is set now, once it is set, no issues, nothing will happen, no manipulation further. जो करते हो उसी वक्त कुछ करना होता है. They say that in the older children, doing this is helpful in keeping the foot supple. वो उनमें 4-5 मिनट के लिए करना होगा. There's an Ethiopian study on this. I think his name is Tim Nan. He's done work on this and he's found that manipulating your child for 5 minutes before you do the casting in the older patient is probably useful. Nan, N-A-N-N, I think इसका published paper भी है. If you look up, you'll find it. Tim Nan from Ethiopia.
So in first cast we will do supination and abduction both.
In every cast, supination and abduction. Don't just forget that first cast. First cast, वहीं गड़बड़ हो रहा है. वहीं patients आते हैं incomplete corrections.
Delegates have another rubber model also.
So they can start practicing, form teams and start practicing. I'll just oversee.
You can apply in front of sir also. Anybody who wants to put plaster directly over the foot can do it. You have a rubber.
I'll watch, you can do the casting. Thank you. Thank you. हफ्ते के लिए
क्यों बन जाते थे
क्या क्या 10 दिन में गड़बड़ हो जाएगा? नहीं, अभी मेरे पास आने से पहले एक बच्चा था सर, शादी है, ज़्यादा ही
आप बोल दीजिए जहाँ साइंटिफिक सेशन चल रहा है वहाँ जाना है, ठीक है?
On the delegates, the second part of the session on the report. Now we have all already learned the way all the clusters, density method, how it works. We all reasonably adapted that. We discussed about the relaxation support. Keep silence please. Waiting for some silence here. Yeah. So if you start off your career in clubfoot or pediatric orthopedics or even general orthopedics, clubfoot is such a common thing that you have to learn all the ways to and the tricks to treat it. You have learned the Ponseti method, you are going on with your practice, and over the next couple of years you start seeing your own cases. And they are not very happy with the foot shape, some of them are clearly working oddly. What do you do? So relapses in clubfoot are very, very common. I'll just start off with a brief quiz just to know what delegates know about this causes of relapse. So may I know just with a show of hands, what is the commonest cause of relapse in clubfoot? Is it the severity of the clubfoot? The clubfoot was severe to begin with. Was it incomplete correction achieved during the primary treatment? Was it improper brace that was applied? The brace was not as per the recommendations, or was it non-compliance with the bracing protocol? What do you feel is the most common cause for relapse? Anybody else? Four. Second also. Second also. Okay, all right. But your own patient has come for follow-up and with this relapse. What would you say? You can't say 0.2. Okay. The next question. It's a 7-year-old child with a relapse. Now, what method of treatment would you choose? What comes to your mind first? Is it a Ponseti technique or a posterior soft tissue release, anesthesia with osteotomy, or SCM fixation? Number 4. More votes for number 4, I think. Okay. What proportion of club feet require Diwali's anterior transfer? Is it less than 5%, 5 to 10%, 10 to 20%, or 20 to 30%? Option 2, option 1. Is it required very frequently or once in a while? Very less frequently. Alright. And what is the appropriate indication for Diwali's anterior transfer? Is it a rigid forefoot adduction? Is it the child gaining weight on the lateral part of the forefoot? Is it dynamic supination of the foot, or is it persistent heel varus? 1. Show of hands for 1. 2.
3, 4. Okay, quite learned audience here. Okay. So relapse has very many definitions. Actually, in Indian literature or as we were training in our MS, we were taught definitions for recurrence, relapses, resistant club foot, rigid club foot, and distinctions were drawn in between all these conditions. But actually, it's a question of treating a foot which was previously treated, probably partially or probably completely. It was well corrected and has developed some attributes of club foot again. So definitions in the literature vary. Some of them have put out figures like dorsiflexion less than 15 degrees or heel varus because that is the most common relapse form that we see. But any foot which requires any additional treatment in the course of follow-up, who has been treated earlier, we broadly put it as relapse. Why we say this? Because our treating methodology has more or less condensed to Ponseti. And that is why our options again in relapse are again condensing into one form, again Ponseti. I will talk about it again in due course. The pathogenesis of relapse is mostly the muscles and the soft tissue. It's nothing to do with the bones. The bones are deformed because of the deforming forces which are acting on the bones. Mainly the ligaments and the muscles. There have been studies which have documented the volumetric mass of the muscles in the leg compartments. All the 3 leg compartments are involved and there is quite significant difference in the volumetric volumes of the muscles. These and muscles grow only depending upon the stage which is given to them. The bones are normal. Remember that bones are normal. So don't think that the bones or the ligaments are the more prime culprit. Maintaining the correction is very, very important and that is liable to miss because of the muscles not growing properly. As we see here, the relapse rate declines very rapidly in the initial 3 to 4 years. That happens because the foot grows mostly in the initial 3 to 4 years. The foot grows to the half of the adult size within 2 years of age. What that means is the bones of the foot are growing at a very rapid stage while the muscles are not able to keep up with them. And the muscles, if they have been left in a subluxed or in an under-corrected position, they are continuing to exert a deforming force on the bones. So this is why the relapse rate is very, very high in the initial age itself. And as in the previous talk it was mentioned, the pathogenesis happens up to the age of 4 years and that is how the bracing protocol was developed for up to 4 years. So that is the time when the most growth is happening. The pathogenesis is relapse is poor stretching of the affected muscles. The muscles are not being stretched adequately because of the inadequate use of brace or exercises, inadequate brace wear and rapid growth of the bones. What is the incidence of relapse? It is again varied between various studies, anywhere between 3.7 to 67.3%. But roughly, you can say in your practice about 1/3 or 1/4 of the patients will come back with relapse. Even if you have done the Ponseti method very well and you have documented that the feet have been very well corrected, everybody is happy that there is very well treatment. And again after 1 or 2 years of age, they are showing some signs of recurrence or relapse. The relapse will be something that you will see the longer you stay in your practice. Now, various studies have tried to find out what are the risk factors associated with relapse, and the number one cause is poor adherence to bracing protocol. If the child is not being braced well, that is the leading cause why the feet will relapse into clubfoot again. Other causes, which are minor causes, are age of the treatment, start of the treatment, severity of deformity, small calf has been associated with recurrence or prior surgery. All of these are very, very minor contributors except for the number 5. If the surgery has been done in a young child, you know that the child's foot is growing very rapidly in initial 3-4 years. If any surgery has been done, definitely that foot is very likely to have a relapse. But if the surgery has not been done and only Ponseti method has been followed, even then poor adherence to bracing protocol is the number one cause. And why bracing is that important? This is another study, it is there at the AAS website, in which patients who had prior treatment and were adherent to brace, the recurrence rate was only about 12%. while the patients who had no prior treatment were treated according to constantly and they were not compliant with brace, the recurrence rate was up to 93%. You can see the dramatic difference in those figures. It's only because of non-adherence of brace protocol. Even if the surgery was done, the last two lines, surgery or prior treatment was done, and then again they had a relapse and they were adherent with brace, the recurrence rate is only 20%. And if the second time also they are not adherent with brace, the recurrence rate is up to 96%. All of them are recurrent. This tells you the importance of bracing. How do you, when you are sitting in the OPD, when you are seeing the patients in follow-up, how do you make sure the parents will tell you that we are using the brace properly, full day the child is wearing, but how do you know objectively? There are some braces which are censored in them, which tell you what the usage hours and all that. But clinically you can see this hourglass kind of constriction is there at the ankle. Why this happens is there is some swelling in the forefoot because of the inactivity and condition as well, and there is some swelling in the calf area. But because of the straps being very tight in the ankle area, which are holding the heel in contact with the sole, there will be a constriction there. If this is there, then that means that the parents are doing their best and the child is wearing the brace full time. Now, once we are sure that the poor compliance with the bracing is the reason for relapse. What is the reason for poor compliance? Why is the kid not wearing the brace? The number one cause is poor fitting of the shoes. The authorities, the way they are manufacturing the shoes, somewhere or the other, the child is not comfortable in them. So if you have corrected the foot very well and the child is still not wearing the brace, the fault lies with the shoes. And there have been studies which have documented the correction even with the shoe does not have to have any fancy design in it to correct cavers or adduction or anything like that. Any well-fitting shoe, if it is fixed with the other foot at a reasonable distance and external rotation of about 60 degrees, that will do the job. That is why all the braces which have been described, always they will have an abduction bar and they will have external rotation. None of them, there will be many variations in how the arch is there or not, the heel is, there are ways to keep the heel down, there are ways to check whether the heel is in contact with the sole, but they are just the minimal differences. Any comfortable shoe, if held in external rotation of 60 degrees and attached with the other foot, will do the job. So the number one cause is poor fitting shoe. If the foot was corrected very well to begin with. Otherwise, the foot was probably not very well corrected, there was some amount of varus or equinus left in that, and that is why the shoe is not fitting well. If the child is, the parents say that initial 3-4 months the shoe was tolerated very well, and recently over last 2-3 months the child is not tolerating the brace well, that means that you have to see whether the deformity is recurring. Even before the child has started walking, probably the heel is turning in, or probably the mild degree of varus or equinus was left in the initial correction. That is another reason why the child may be intolerant of bracing. And sometimes the patients are so confident that the deformity has been cured, they just give up on the bracing. That is the very remote third cause. But initial first two causes are mostly the common causes. Shoe is not fitting very well, or the correction was improper to begin with. How do you tackle early relapse? Start with Ponseti again. There is enough literature to suggest this. Now all the surgeries, like our previous speakers have also said, most of the surgeries are now on the downside. Ponseti works for adults also, like sir was saying. So repeat your Ponseti protocol as per the protocol individual plasters. There is no need to vary the duration of the plaster, but if there is issues with logistic, every week the child cannot come. Sometimes we call them back in 10 days or 2 weeks time. Sometimes the feet are rigid, then we give them 2 weeks of rest in between the plasters, but the sequence and the manipulation, the protocol remains the same. Tenotomy has to be done after the abduction has been achieved, and bracing, again comfortable shoes with bar. This is a 4-year-old child. It was treated in infancy, and he has been on calipers since that time of correction. Now he is 4 years old, he has come to see me. What would you do in this situation? What kind of management would you prefer to do? He is an active 4-year-old kid running around in the OPD. So it may seem very inhuman to put a child who is so active to put him back on the class steps, but the class steps give you very supple, flexible feet. Ponseti works for an older child, mainly it is not about the correction of the deformities. The foot which is there at the end of the treatment with Ponseti is a much more flexible, pain-free, fully functional foot. The child can run, child can go for walks or mountain climbing or anything. But after surgery, the feet may look good, but they will be very, very stiff, they will not be very, very functional. So always, whatever the age may be, don't rush into surgery. Any old child can tolerate the plaster, there are ways to make it more easier for them to tolerate. The casting principles remain the same. You have to apply a above knee cast with the knee flexed as much as possible, and you have to spend more time manipulating these feet. Ideally, even in Ponseti, you have to spend some time 2 or 3 minutes or 4 minutes of manipulation before you put the next plaster on. But here, probably you have to manipulate for 5 minutes or 10 minutes. And what I usually do is I teach the parents to do it. I tell them where to put their thumb and how to apply the plaster, and I always tell them to bring some amount of coconut oil or whatever they wish to apply between the plaster changes. So that time they do the massage so that handling does not cause so much pain. The moment you remove the plaster and apply the next plaster, there is bound to be some amount of pain because of the stiffness of the plaster. So let the parents do that. Let them actually work for 15-20 minutes, and then you come in, you apply the plaster. An active child will probably break the POP, so you can put the last layer as the synthetic plaster cast. But always remember that the cavus, the forefoot supination has to be maintained. That applies to all ages. And if it's a very active young child, then probably after the second or third plaster, the knee flexion can be reduced to about 60 degrees. Just to make the child walk, and within the confines of the house, with a 60-degree bend of knee, the child can usually move around. So that is a easy compromise, but actually I don't put any below knee plaster even till the last plaster. And then once you have got a reasonable amount of abduction, you go for a secondary tenotomy. Up to 2 years, percutaneous tenotomy is very, very safe, like sir showed in even an older child. But usually for an older child, if a sizable tendon is there, you can also go for percutaneous 3-cut, triple cut, both technique of tenotomy is there. That I'll show you in one slide here. Or sometimes we need to go for open endoapious tenotomy if the child has had some prior surgery. This is a child who has had a relapse of clubfoot. He was previously operated. As you can see, there is a long scar. Now this child was operated in infancy. Any surgery in infancy, probably it's like 95% chances of recurrence, if you ask me. Because the main time of foot, the growth of the foot is still there. So before 4 years, be very, very cautious in putting any knife to the child for an extensive surgery. So we started with plasters, we got a reasonable amount of abduction, and then we took him for the T8 release. Now this child was already operated earlier, so we opted for an open T8 lengthening rather than percutaneous. Hope and everything, whatever you can do only if there has been no prior surgery, open surgery there. Why? Because as you can see here, there is a big vein over there, right? I'm not sure whether you can see that or not, but there is a big vein over there. And other reason is once you have done the tendon lengthening, you can see that the peritenon is also having quite strong fibrous bands over here. So you can't do all this correction with just a percutaneous release. Sometimes you have to combine that with plantar fascial release. I usually do it with the needle. That is usually sufficient. The same technique, you put the needle obliquely and cut against your thumb pressure. Limited posterior release, this slide I am just showing that you have an option. If at all it's a very resistant kind of foot and you are not able to get any good correction, then you can do this. But usually it is reserved for like 1 or 2% of the cases. Right from the posterior incision itself, you can do the release of subtalar joint and the ankle joint. And you can, this is the subtalar joint, this is the ankle joint here, and you can reach into the lateral part of the joint also, and if you want, you can release the calcium fibular ligament also from here. That is usually the last gesture which is there. But with the Boacon technique, probably you don't have to do this for almost 95% of the cases. And then tibialis anterior tendon transfer. It is a kind of bracing. So what I wanted to emphasize was that when do you apply a brace? When you have achieved the full correction in Ponseti method or whatever kind of technique you are using. The tendon transfer also works on that same principle. The deformity should be passively fully corrected. Then only you have to think of tendon transfer. It is not for a residual metatarsal adductors or forefoot supination is pronation is still there and we will just get on with this tendon transfer and that will take care of the forefoot. It's not going to happen. Your foot should be supple and fully corrected before you do this. Ideally around 4 to 6 years of age when you start seeing the ossific nucleus of the lateral uniform on the CM image. And it is a very satisfying surgery. Fixator assisted, again we have subsequent talks on this. I'll just wind up. This is where we have done a whole technique of reading, and then this is a 5-year-old kid where we have applied a plaster because because he had a prior surgery. So prior surgery patients may not do very well with Ponseti. Again we start out with Ponseti because that makes the job easier. And this is a 17-year-old kid, a man you can say sculpturally mature, who has been corrected with Ilgaro fixator, but the principles of Ponseti, no osteotomies were done, no joint releases were done, just interrelease release was done, and this is the picture at the end of the fixator. So in summary, prevent relapse, know how the relapses occur. Relapses occur because of poor brace compliance, and poor brace compliance is almost always because of poor shoes. Take care of that. Ponseti technique works even for a older child. Avoid PMSCR, CSCR and osteotomies. And again, once you have corrected, brace them well. Thank you.
Any questions here? You can have all the questions together also.
So mine is a very small talk. Good afternoon, everyone. And I'll be made easy okay because Saurav has already mentioned about the dynamic adduction, the tibialis anterior transfer. That is what this talk is about. So coming to dynamic adduction in clubfoot. So basically, as mentioned in the previous lecture, the relapse in clubfoot, basically we can classify those into 3 categories. Grade 1 is a supple feet. Grade 2 is a deformity which is usually present, one deformity in one of the planes, corona or sagittal, and grade 3 is combination of 2 or more deformities. So grade 1 supple feet, it has subparts like type 1A and 1B. This classification was given by Dr. Atul Bhaskar and team in 2013 in Indian Journal of Orthopedics. So grade 1A is where the feet is supple, but there is equinus. We can bring back to neutral or dorsiflexion even. And grade 1B is dynamic adduction of the or supination. And this is what we are going to talk here. After that, grade 2 and 3 are fixed deformities. They are no more supple. So what is dynamic adduction? So what happens, just say we can see in this video, when the child is standing, it appears that there is no deformity at all. The foot looks good, plantigrade, but as he is walking, so just observe there. So during the swing phase, what happens? The lateral border of the foot strikes first on the ground, and there is a supination of the foot. The medial border kind of lifts off, so that is what is dynamic adduction. Okay, once more. So the lateral border is hitting first and the medial border is lifted up and it is in supination. So initial contact is along the lateral border of the foot, and with time, if it is not corrected, it also develops lateral plantar callosities. This happens because the peroneus on the lateral side, they are weaker, and comparatively, relatively, tibialis anterior is stronger. Again, when the patient is asked to do an active dorsiflexion, there is a forefoot supination relatively to the leg. So this is dynamic adduction. This is how it is diagnosed. Is it a relapse? Yes, it is a relapse, because again, if it is not treated, it will become a fixed deformity. At the same time, some children, they have inherent property since at the birth. Once they start walking, it becomes apparent that there is that kind of deformity is there, which is near about 2nd to 3rd year of the life. And again, as said, if it is not treated, it becomes a fixed deformity. The incidence is somewhere in different papers 10 to 50%. So for the fixed deformity, we know, as Dr. Saurabh just mentioned, we can do either serial castings or soft tissue releases or bony corrections. But for the dynamic adduction, so basically it is because it is a soft tissue problem. The tendon transfer is what is always needed in this. So as seen here, the lateral cuneiform, that is what is seen there with the red marker. So that develops near about 3 to 4 years. That is the time where these patients present and they might need a surgery. So the entire tendon of tibialis anterior, it will be lifted from the base of the first metatarsal from the medial side and will be transferred to the lateral cuneiform. Okay, so there are various techniques from the different papers, whether it might be transferred to the fifth metatarsal base or the lateral cuneiform, or there is 2 incision technique or 3 incision technique. The 3 incision technique, they say that it is better and for a stiffer feet, for a stronger, it gives a stronger and direct pull, so better correction. So this is how it is done. So there are 2 incisions in this, a medial incision and a lateral. The medial is over the tibialis anterior. This is how it is identified and lifted up, and then couple of sutures are then taken up into the tendons. This is how it is released from the fascia nearby, and that is how the sutures are passed. And then the lateral cuneiform is identified under Sion guidance. A drill hole is made. It is passed up to the plantar aspect, and then the tendon is then passed from the medial to the lateral aspect and pulled out from that incision. And remember, it is still superficial to the extensor retinaculum. It doesn't go below that. And finally, the tendon is passed on the sole, and we might use a button, or we can just roll the gauze piece, and over that the tendon is tied. We can finally apply a couple of sutures on the dorsum side just to give an additional stabilization to the tendon. Finally, this has to be left in cast for near about 6 weeks, and whatever bracing protocol you are following after that has to be continued. So there are various papers. This paper is of 35 patients and 60 clubfeet treated, and this is a very long-term follow-up, 47 years average follow-up, and this says that the tibialis anterior transfer is very, very effective in preventing the additional relapse of the deformity without affecting any long-term foot function of the patients with clubfeet. So this was one of our cases, again that the lateral border of the feet, bilaterally touch the ground first, the medial side there is supination, no other deformities, no equinus. This is a 5-year-old child, and those are the x-rays. So just to again show the medial side, the tendon is identified, it is cut, lifted, and then couple of sutures passed. And then on the lateral side, the lateral cuneiform identified, drill hole made, and it is dilated just to make the easy passage of the tendon. And finally, an incision on the sole, the tendon is retrieved from there. That is how the tendon is retrieved, and finally it is tied over a gauze piece, left in cast for 6 weeks. Again, the same thing to be followed on the other side also, in the same setting. And this is the final 1-year follow-up. There might be, there is a little forefoot adduction, but the dynamic adduction of the lateral border touching first, that is all right. So that is all I talk about. This is one of the important things, and it has to be corrected because otherwise it will lead to a fixed deformity. Thank you. Any questions?
Justin, while tightening the tendon, fixing it on the lateral, what should be the position of the foot?
Sir, if there is an additional TA tightening, it might be there. Ideally, it should not be there when we have to release. Otherwise, we fix it in the maximum dorsal flexion.
Any questions from the delegates? Thank you. We can proceed with the next talk on JS fixation in left foot by Dr. Sashika.
Good morning everyone. So I will be discussing role of chest in clubfoot, introduction to implant and implantation technique. So first about few lines about Dr. Joshi, the name of whom this fixator is named and who devised this fixator. So Dr. Brajbhushan Joshi in the year 1950, he obtained postgraduate degree of MS in orthopedic surgery from Bombay University, and he was first ever postgraduate in orthopedics in India. He is one of the pioneers of hand surgery, not only in India but world over. Although he was not trained in hand surgery as it was not non-existent, but he himself trained and developed his acumen. He was renowned for his knowledge, ingenuity and innovativeness. I am happy with the available external fixator while dealing with industrial and agricultural accident involving crushes and mangled limb. He evolved a fixator device for stabilization of hand and the foot. So he was consultant of an ESI hospital where so many levels of crushed hand and crushed foot used to be there. So usual external available fixator were not adequate to deal with those limbs, and he devised this Joshi external fixator, which was later on found to be very versatile and which was found to correct so many different kind of deformity, and it was non-constrained kind of fixator. So Joshi external sterilization system is simple, versatile and light fixator system with tremendous potential. It includes a bloodless, semi-invasive procedure that avoids fibrous tissue formation, further shortening, post-operative complications and scarring. And proper control of all component of correction is possible with this, as it is non-constrained type of fixator, by causing actual physiological lengthening and histiogenesis of soft tissue, thereby reducing the pressure on the growing epiphysis. So it is indicated mainly in those relapse cases of CTEV which are not getting completely corrected by Ponseti method, or syndromic neurogenic kind of club foot, or late presenting cases which after applying Ponseti not getting completely corrected. So those cases are the candidate for this chest fixator application. So clubfoot is a multiple apical deformity, and the apices are very difficult to determine. The frame must therefore be non-constrained. Ilizarov is a constrained frame, whereas this Joshi is a non-constrained frame. The child foot is cartilaginous and no compression across joints should be there, because if any compression is there, this will lead to damage to the cartilage with ultimately deformed bone and deformed foot. So differential distraction avoid this compression. So rate of distraction on, what is differential distraction? Rate of distraction on concave side is double the rate of distraction. So this concave side here, this side rate of distraction is double as compared to convex side. It achieves a skeletal hole in each component. So there are three components: tibial component, calcaneum component and metatarsal component. So we apply wires, we hold them with the help of arches and those clamps, and separate assembly is there in each region: forefoot assembly, hindfoot assembly, leg assembly and pair distractor. Forefoot to hindfoot, these two distractor, and from hindfoot to leg. So what are different instruments? Z rod, L rod, these links, connecting rods, K wires, distractors, we need drill. So these children are usually operated under general anesthesia in supine position. So first we introduce tibial wire. We can see that first wire is 2.5 centimeter below the tibial tuberosity and it is lateral to the tibial tuberosity. So two parallel transfixing wire in tibia 2.5 centimeter below and lateral to tibial tuberosity and perpendicular to the longitudinal axis of the tibia. Length of the middle segment of Z wire is marked below the first wire and the second wire is passed parallel to the first wire at this level. So Z
that Z clamp's length is marked below first wire, and then second wire is passed, and which is parallel to the first wire. Now calcaneal wire, two transfixing parallel wire are passed into tuber of calconium from medial side to lateral side, and one axial calcaneum wire is passed posterior to anterior, just distal to insertion of a carriage tendon in the longitudinal axis of calcaneum. We will see it. Then metatarsal wire, we pass one wire from lateral to medial in the region of neck of the metatarsal, and it should engage at least fifth and first metatarsal neck. Then two separate wire, one from medial and one from the lateral aspect are inserted parallel to first wire, and it is made sure that all the metatarsals have been impaled by at least one of the wires. So now tibial hold is made by linking the Z clamps with the help of a link. Then one rod is connected superiorly to this Z clamp and one rod inferiorly to the Z clamp. So this is inferior limb of the Z and this is superior limb of the Z. So this connecting wire superior and this connecting rod inferior. Now calcaneum attachment, two L rods are attached to the transfixing calcaneal wire on either side of the heel, and behind the foot these rods are controlled to each other by a connecting rod to which the axial calcaneal clamp is. So here this is axial calcaneal wire which is in line of the axis of calcaneum, and these three are connected. Now metatarsal attachment. Two small L rods are attached to the metatarsal wire on the medial and lateral aspect of the foot. Here there is a slight difference. Here we are seeing that three wires are there. Ideally two wires should be there, but after putting, this was first wire, after putting this second wire, I was not very sure that whether it has engaged metatarsal, and I don't want it to put make another hole, so I just put another wire and fixed it. Now tibiocalcaneal connection. So tibiocalcaneal connection posterior, this posterior limb of Z is connected with this interconnection rods, and distractor are attached near the transfixing pin. Now calcaneal metatarsal connection, a pair of appropriately sized distractor is attached to calcaneal and metatarsal wire on either side of the foot. Then tibio-metatarsal connection. These connections, simple rods are there. These are just to stabilize the frame, and every week we have to readdress it and we have to reattach it. So the anterior limb of the Z rods are connected by a pair of rods to small L rod anterior to the metatarsal wire, and two anterior connection rods are connected on the medial and lateral aspect of the assembly from the transverse connecting rod of superior limb of Z rod to metatarsal wire inferior limb of the metatarsal distally. Now, rate of distraction. On third post-operative day, we start distracting, and differential fractional calcaneal metatarsal distraction on the medial side is started at twice the rate than that of the lateral side. So, medial side 1/4 of turn every 6 hours, and on lateral side 1/4 of full turn every 12 hours. Then tibiocalcaneal distraction is carried out in two positions. So in heel, first we try to correct varus, and second stage we correct residual equinus. So first distally, first we attach our connection over here, and once heel varus get corrected, then we reposition to the posterior side so that only equinus is getting corrected. So this is final correction. So following the correction, the assembly is held in a static fashion. Usually it takes 3 to 6 weeks for complete correction of the deformity. Once this complete correction of deformity is achieved, twice the time taken for correction of deformity, ideally we should keep this fixator on so that maturation of a stretched tissue is there. So single stage removal of whole assembly is done under general anesthesia and a well molded every plaster cast is applied with maximum correction for 2 weeks. This is once the pin track heals completely, a Villoni cast is applied and the patient is asked to ambulate with full weight bearing in plaster and it is removed after 4 weeks. Thank you.
Thank you, Dr. Sasikanth. Excellent presentation. Delegates can see a present model of JES applied on a foot model by Dr. Arun Kumar, Head of Department from SKMC. Sir is sitting behind to help you if you want to see after the session. And I will be moving on to Elizaro Basics in Clubfoot by Dr. P.N. Gupta sir from Chandigarh. For this you can see the model at the end so that you will be more clear about pins and position and links when required.
Alright, this is a very small talk as it just has clarified a lot of things. So basically, as in JES, we have 3 areas to hold. One is the leg, other is the calcaneum, and third is the right. So, question is Elizarov suitable for anybody? Perhaps not. It's painful to have an Elizarov or external fixator in place for 6 weeks, 4 weeks, whatever. So there is indication for Elizarov or for that external fixators. When there is a stiff, scarred foot, you can see these 2 conditions. Stiff and scarred foot. You try to stretch, they are not. Unable to stretch it using a gentle force. So you have to use a little more brute force, but you can't sort of break it. So what you do is use a brute force little gradually so that the person doesn't feel it, and that is done by these fixators. The one condition which is very reluctant for treatment is a equinus in a flat dome Dallas situation, where forceful manipulation has been done and there is a flat dome Dallas. So there are some patients who are very stubborn to get corrected with high incidence of relapses. So these are my indications for putting in X-fixes. Stiff feet, especially where previous surgery has been done. Flat dome Dallas with a lot of equinus. So basic construct is leg construct with 2 limbs. Foot construct calcaneum and forefoot. So in the leg, I am not going to go into the details of the basics, how to stabilize it. But please remember 8 cortices have to be engaged for it to become stable and in different planes. So Elizarov allows you more modularity. So you can pass the wires like this, you can pass a pin, you can pass 2 wires, you can pass a pin perpendicular, that will give you more stability. So 8 cortices. Similarly in the calcaneum, classically 2 olives have been described, medial angle. The problem with the calcaneal ring is that sometimes you have so lesser space to adjust these wires. So I put in a posterior axial pin as well. And similarly in the forefoot, you have to engage all the metatarsals so that there is no secondary deformity in these muscles. I use additional chance pins in the first and the fifth. That will give the forefoot more stability. And 1 additional pin or wire in the neck of the pelvis. Neck of pelvis. Then is the hind foot to forefoot action. You place hinges, two hinges, one medial, one lateral, and you place your distractor posteriorly and a shade medially because you are correcting the inversion also. So not dead posterior but a shade medial to the posterior. So that will give a force posteriorly as well as an opening force medially. Then is leg to, yeah, this is what we have discussed. And then the hind foot to forefoot you are connecting by two hinges. Yeah. So you are connecting by two hinges, one medially, one laterally. One laterally, one medially. And I tend to use a pin here. These are one of the older slides where the pin is not there. But now I will use a pin, additional pin here easily to have more stability. So this is the completed construct. The left hold, additional pin or wire in the neck of talus, the calcaneal hold, and then these yellow ones are the threaded rods. This is the ring in the foot, and they are connected medially, laterally, and a posterior distractor. So medial and lateral connections are at the level of the malleoli. And similarly, one distractor, one hinge here, one hinge on the other side, and these are connected, and then this ring is connected by a single sort of hinge from here, foot to the something similar to this. Nothing much different, the basics. Right? So you distract this, and from this. So this is how the diagrammatic thing this will look like. So two modes you can use. One is the soft tissue distraction mode, which is usually used in younger patients. And second is, remember what we discussed in the Ponseti, the subtalar joint complex. But here it is so stiff. So you sort of create an artificial subtalar joint complex by a V osteotomy or a U osteotomy, something like this. This going through the talar neck and this going through the calcaneal artery. So you are sort of creating a pseudo subtalar joint along which you are correcting the deformity. Right? So this is osteotomy and correction. One of the problems of external fixators, as with Jess, you have the clawing of toes. There are various ways to address this. I think some people put wires, I don't put wires. Some people put straps, rubber straps. What I do is gentle stretching by the parents. I have always found that manipulating the toes at the time of putting the plaster. I have never faced a problem of clawing of the toes at the end of plaster removal. So we just sort of gently stretch them under GA once you have applied the plaster. The second problem sometimes is a technical issue if you apply the second ring too low. This ring sometimes is hitting the skin. Once the equinus gets corrected. So this is a technical problem which I faced once. So numerous other configurations, Ponseti configuration, single stage, two stages. I am not going to go into details and not going to confuse you. So points to remember: leg to calcaneum connection by hinges medially and laterally. Calcaneum to forefoot connection, medial distraction, and if you place your hinge somewhere here, below the foot, so it will correct the cavus, it will correct the forefoot connection. So that's the key points today now. So I think I'll stop here.
Thank you, sir.
Dr. Shamsul will be, I think, demonstrating.
Yeah, Dr. Shamsul will be demonstrating the video presentation, how to apply this frame. At the same time, we have one model also to discuss about it. Due to shortage of time, we are not moving to a hands-on workshop on the ESOL. So we will be discussing everything in the videos here.
Thank you, sir. Thanks everybody for inviting me. So this is very important step. We are going to learn the basics of laser frame technique. I welcome you all on behalf of Boacon and Assam in India. So this is a frame that looks very complex, but if you learn this step by step, it will make you very, very simple for this. And this is pure Kurgan laser technique that I learned from Kurgan. We just added a few shots for your easy. Otherwise, it's a pure white frame. So what you need to put laser in clubfoot to place optimal circular external fixation in a complex clubfoot deformity resulting in a normal functional foot. You can see patient is having a deformed foot. It's not easy to go with soft tissue, it cannot be easy to go in this age. So we are dealing with an adult patient. So laser some moving corrections which are very good results, just like this. You can see the initial deformity and the end deformity in the left foot. This is very easy to do the process very well. Similar in another case. So be it any age from 5 years to 10 years, we apply laser, below we apply yes. So this is the happy clubfoot family. So as Pedros has said, we have to go along the basic principles of laser. We do the adduction corrections between the metatarsal and calcaneum. Destruction across traumatic different joints, virus corrections between tibia and calcaneum, destruction across anterior and parallel joints, and then equinus correction. These are the steps between the metatarsals, calcaneum, and tibia, rotation on metatarsal, parallel axis. So these are the place of corrections. We have to correct the canvas, adduction, connection, virus heat, and equinus. So these are the basic steps you see with L0. We just correct equinus. So this adduction we correct from here, 20 to here. This is a tibia frame, calculating the foot frame. This is the correction of adduction. Then we go on the plantar side, same. Then we do the virus correction, the obliquity, we correct regularly, completely, and then we have to do the equinus correction. These are the various steps. So these are the steps I learned. These are from the OT of Kurgan Dadila. We'll be applying the same frame. This is in a children patient, pediatric patient, and same. I repeated in my patients. This is a patient who has this spine. So we'll be learning this frame one by one. So we have here tibia frame, calcaneum frame, and a foot frame. So the basic steps, as you can see, we first do the first you can do the TLNE, plantar fascial release, we apply the tibia rings, we apply the calcaneum half rings, then metatarsal osteotomy or V-ostomy if needed. If you have a flat long talus as Pete was said, then you can put half rings and toe as needed. So I said, the many times you get clot goes. So toe wax is very good help to qualify correction in these cases. So we can do TLNE if needed and plantar fascial release. These are the first soft tissue steps that we mostly need to do. This gives a very good correction initially. Then we apply the tibia rings. So we have two tibia rings as you can see in the photograph. Additional, the proximal ring, we just place these things around 3 to 4 fingers. As Sir said, we have to adjust the footing. We just don't apply as we do usually in a tibia frame. Rule of two. We just have around 3 to 4 fingers proximal to the ankle joint. We do two kevas, laser wires like this. Another ring, just another ring. Usually use the big red ring like this. So this is the first step. 2 tibia rings made in a frame. Then go to the next step. I'm making this in animations, then I'll show the video to you so that you learn. And so this is the tibia frame. In a tibia frame, I'll show you. I'll show you the video. Then we apply the calcaneum half ring to cross kvass in the calcaneum and a half ring. Like this. Then we can do a bony corrections like we do a mid-tarsalostomy with a miniopin incision. Then we have a bony deformity like flat on callus, as I said. We can do a mid-tarsalostomy, we can do a gastostomy. And you can see the results in X-ray with this ostomies, venation and dagger. Venation and the dagger. This is the ostomy level you can see here. Then we apply the foot half ring to cross kvass, first and second metatarsal, and then third, fourth, and fifth, and a ring. Then we connect the hinges, medial and lateral hinges. Then we put the corners from the foot ring to the tibia ring, 2 hinges. I'll show you in the video. Again this, and a calcaneal posterior hinge. And in across the callus, right across the callus. This is a complete animation for this. This way you can get a correction, different directions. You can do the dorsal correction and abduction corrections. This way you apply the hinges, explain all the hinges one by one. Program patients and my patients. Then we apply the connectors, one level. We repeat all of this in a video. So this is the final discipline for the left foot without 2 wires. And if you need, then you can apply 2 wires like this. If you have a broad rope, you can apply 2 wires for a complete correction. This is the figure. We apply the wires with the minute and run with the connector with the foot ring. So these are 2 wires. This really helps in correcting the cross toes. These are photographs and demonstrated in the studio because we don't have 2 wires. The toes are really small, so I have not applied the 2 wires here. You will see the pictures from here. So this is the final assembly. So we repeat here. 2 tibia rings, calcaneal ring, full tree, then the hinges, connectors, and the 2 wires. So this is complete correction. It's a well connected smile. So this go to the videos. So we first apply the tibia frame. We usually apply around 3 to 4 fingers proximal to the ankle joint. Not exactly as we apply the usual tibia frame, we apply just 2 cm here. But in this case, just to adjust the foot rings, we apply 2 tibia wires. One different one from here, second different one from here, then again 2 oblique wires from here. So we apply 2 wires each, or we can add with to shank slip in this cases. Consider the first one is going on. In second reference wire, the proximal ring. Then proximal cross wire, that is third wire. A distal cross wire. So do you have any confusion in this? These are 2 proximal tibia rings. This is the reference. Let's repeat for you. These are 2 proximal tibia rings. These are reference wire. Posterolaterally, ventromedially. another wire transverse to the tibia, and then we have cross wires around the shin, cross wire around the shin. This is the first assembly, the proximal assembly of the tibia, where we apply the proximal tibial ring. So after applying this, then we apply the calcaneum ring here, okay. So now we go to the next step. I repeat everything on the ring again. We cut the wires, we bend the wires, and then for your easiness, we apply 2 shank screws. Now we come to the calcaneum ring. So in the calcaneum, there is a calcaneum ring. We apply 2 cross wires along the calcaneum. Okay. So usually we apply the thread goes above so that it doesn't depend towards the floor, to the floor. So 2 cross wires here, we can apply one shank pin over here. So this is a very good construct. Apply tibia rings, apply calcaneum ring, then we have connectors. I'll just tell you how to connect the hinges. Now we come to the foot ring. So we have connected the calcaneum ring to the tibia frame. You see the joints, it makes a universal joint, move in any direction, so it gives a complete correction for this adduction and varus and cavus. Then we come to the foot frame. We apply the first wire from the first and second metatarsal. You can see here. It's an oblique wire. We go like this, and another oblique wire from here. First two in the first wire, third foot frame in the second wire. The 2 oblique wires, we apply a foot ring like this. Okay? Then we connect with the calcaneum ring. So these are the foot wires you can see, you just pass through the neck of metatarsals. The first one, the first 2, those. Second start from the 5th, 4th and 3rd. Then we connect the foot frame with the spiral connectors and hinges to the rings. You can see in the video, I'll tell you every step on in this frame. You can see there's a free movement in all the hinges. So now we have connected the foot frame to the distal tibia ring. We have made a joint with the male and female. We applied a spiral plate to the tibia ring, and then a male-female post. We have connected the rods. So this way, if we apply one male or female, we can move the joints in all the direction. You can see. This makes a universal joint. You can do any movements with this. Once we have connected, you can see the range of motion. You can do the RS direction, motion correction. You can do the equinus direction with this. It should be free movement. It's very important. And the middle lateral hinges should be the level of tarsals. So this is the final assembly. So with this I repeat for you. This is the proximal component, the tibial component. This is the first reference wire going through the fibula to enter the medulla. Second reference wire transversely to the tibia. Third again from here, oblique to the medial ridge of the tibia. Another oblique along the sheath of the tibia. Either you can apply 2 wires, you can apply simply 2 transverse wires and apply 2 shank pins. This is a very simple, you don't need to apply 2 wires here. This is the first part. Then we apply the calcaneum ring like this to cross K wires, one standstill. Then we connect this with the hinges, with the male and female hinges, the male hinge, female hinge, because joint. It's a very good movement. After that, we supply the foot frame to cross wires, the foot ring, and then we connect the foot ring to the calcaneum to the tibia, all with the help of multiple male-female posts. You can see the middle lateral side. And after that, you can see for the correction of this condition we have right now, similar two rods are here. So male-female post is here, spiral plate, two hold two male and female posts, and you can apply two rods here. So if you have any question with this, you can ask me. This is the final assembly. And I'd like to, before I end, I invite everybody to our upcoming Assamicon Goa and become a member of Assam India. We have the Assamicon Goa at 30 and 31st of March. We are having all the programs already here. Not just we have a hip and workshop here. We have different workshop. We have different virtual sessions. We have fellowships for the postgraduates. Everything all on behalf of the Assam India team.
Thank you, Dr. Sanjay.
Can you just clarify on the distraction rates, what rods you distract in osteotomy and what rods you distract in soft tissues? I think this is for the benefit.
So this is the mark for the mid-tarsal osteotomy, as you can see here. And this is the mark for the reostomy. Usually, it's very easy to do a percutaneous mid-tarsal osteotomy. I have done both. So this is very good. So if you done it in osteotomy, you have to wait at least 7 days for this, as you do in the usual osteotomy, and then you gradually extract around 1 millimeter per day for this. In this case of ablation adduction, we have to do lengthy distraction from this side, compression from this side. Okay, distraction on this side, compression on this side, and this works as a hinge for the movements.
Is it clear to you all? We will have this model at Dr. Samsul here, even after this presentation. So you can discuss it and you can clarify all your doubts. Because this osteotomy and distraction, you should know before doing, you should know the anatomy very clearly. And even for the Elizarov wire fixation, unless you come close and do it with the master ones, because many times we can pass the wire from the wrong place also. We can have a spurious connection. Thank you, Dr. Samsu, for talking on Elizarov, and I thank all the delegates for being in part of this workshop. I think a lot of people will be feeling hungry. So after this workshop, you can have your lunch in the trade area, and Dr. Matthew Varghese sir will give his closing remarks on this.
Thank you, Ritesh. Thank you, everyone. Thank you, Dev, Shamshu, everybody. It's actually a long workshop, which is one. Saurabh is also here. Thank you very much. Dr. Taneja left. It's been really nice to be here. Two messages I want to give clearly. One, the key performance indicator for a good clinic is the tenotomy rate should be more than 90%. Two, brace protocol is as important as the fasting and the tenotomy. So the brace has to be for 5 years. First 3 months, 2 to 3 hours a day. After that, night time and nap time. It's an abduction brace. If you're using a Dennis Brown split, please make sure Dennis Brown split is 15 degree. A true foot abduction brace is 70-degree abduction. Make sure your orthodontist knows it. Don't make a mistake of 15-degree abduction Dennis Brown split. It has to be 70 degree to be continued for 5 years. definitely. You've heard all the recurrences and relapse rates and what you need to do. But for the child to have good compliance, nighttime and naptime basis. Do not compromise. But rest of the time, normal shoes. You don't need reverse shoes. You don't need CTV shoes. Normal shoes rest of the time. Is it okay? You're welcome to talk to me today and tomorrow, anytime, any clarification you have, and any of the faculty. And Dr. Shamshul is here to demonstrate the osteopathy and the iris and optic. Apologies for the time. Apologies to Dr. Ramchandra and his team who are waiting to take over from us the podium. Thank you very much. Thank you, Ritesh. And the entire Boacon team have been very generous with their hospitality. Thank you so much.
Thank you, sir. Thank you, Dr. Now we can go for lunch in the bread area. After that, there will be fine workshop. We are starting soon.
Thank you, sir. Thank you.
मेटाटार्सल है छोटा है ना। के वायर का है कि आप अपना आईक्यू लगा के किधर से कैसे
बेंड करना है,
कितना मोटा बच्चा का क्या लेग का साइज है उसको सारे
डिस्ट्रैक्ट कैसे करना है, हाउ
अब डिस्ट्रैक्शन लगा दिया, फ्रेम लगा दिए, 5-7 दिन छोड़ देंगे कि टिश्यू के बाद थोड़ा सबसाइड है ना, बच्चा रोता है 5-7 दिन के बाद हम यहाँ का डिस्ट्रैक्शन शुरू करेंगे। कैल्केनियो मेटाटार्सल दो वर्ड एक उन्होंने यूज किया, डिफरेंशियल डिस्ट्रैक्शन होना चाहिए। तो डिफरेंशियल में सो कैरो साइड है, कनकेव साइड स्विलिंग हो जाता है, उसको रोक है ना। कोई रफ माने क्या कहते हैं, हार्ड एंड फास्ट रूल नहीं है। 3-4 हफ्ता ही डिस्ट्रैक्शन करेंगे, तो 6 वीक्स तक कभी डिस्ट्रैक्शन करते हैं। धीरे आज की कल छोड़ देते हैं। जैसे ड्रग होल्डिंग करते हैं, साबुन का करके छोड़ दी, होल्डिंग करते हैं, फिर रोक देते हैं, फिर देखते हैं स्विलिंग सब साइड करके और दूसरी स्पेडिस देते हैं। दूसरी स्पेडिस का होगा डिस्ट्रैक्शन चलेगा। ये डिस्ट्रैक्शन यूजुअली 4 to 6 वीक्स, इसको भी करके इसको डबल करके इसको हाफ कर समटाइम्स हम लोग बच्चे को घर दे देते हैं 5 दिन के बाद इसको डिस्ट्रैक्शन करके देखते हैं कि कहाँ पर बच्चा हमारे टॉयलेट में जाएगा, टॉयलेट रोने लगा कम कर देंगे, दोनों को कम कर देंगे। डिफरेंशियल डिस्ट्रैक्शन क्यों करते हैं कि अंदर से ज़्यादा होगा, हाँ तो उधर जो कार्टिलेजेस है उसका क्रशिंग
इसमें तो वायरस करेक्शन होना केवल
पहले तो वायरस ही करेंगे ना, वो टेढ़ा पर बहुत है ना, जैसे ही आप करेक्ट कीजिएगा वो टेढ़ा को स्ट्रेच करेगा, समटाइम्स केवस नहीं होता है, टफ रहता है। वो 18 इंच का या 18 नंबर का नीडल लेंगे 7 वाला, और जहाँ पर वहाँ प्लांटर फर्स्ट उसके लीडिंग कर देते हैं, लीडिंग कर देंगे तो उसके बाद ऐसे
स्ट्रेचबिलिटी बढ़
उसके बाद हाँ वो तो देख करके ऐसे मैच करते हैं, प्लांटर फंसा है ऐसे करते हैं, देखते हैं कि हो गया तो थोड़ा डिस्ट्रैक्शन कहाँ पे मीडियम में लाई के जस्ट वहाँ पड़ेगा नीचे न्यूरोवास्कुलर डिस्ट्रैक्शन, थोड़ा डरते हैं है ना, फायदा ज़्यादा होता है, ब्लेड हम नहीं लगाते। तो ये वायरस हो गया सर, उस समय तो एक्सरे नहीं था, CR नहीं था, तो CR में देख लेते हैं। अच्छा हमेशा चेक करते हैं कि हमारा के वाइफ का पोजीशन है, तब हम लोग इसको कैल्केनियो टिबियल डिस्ट्रैक्शन 2 फेज में करते हैं, स्टैटिक फेज 1 फेज 2, इसका पोजीशन चेंज करते हैं। जेट रोड के पीछे लगाएंगे, उसको यहाँ लगाएंगे, फर्स्ट में यहाँ लगाएंगे डिस्ट्रैक्ट करेंगे, और लास्ट 3-4-5 वीक्स के बाद इसको डिस्ट्रैक्ट करेंगे और यहाँ पर एक रोड लगा फिर देख लेंगे एक्सरे करेंगे, फिर इनको रेडियोलॉजिकल डायग्नोसिस करना है। लेकिन हम इतना दिन डिस्ट्रैक्टर चला दिए जैसे लगा हुआ हो गया, तो इनको रेडियोलॉजिकल डायग्नोसिस करते हैं, देखेंगे कि हमारे करेक्टेड हो गया टैलो करके नहीं लेंगे, और फर्स्ट का एंगल देखेंगे टैलो से, यूजुअली नेगेटिव रहना चाहिए। उसके बाद इसको स्टैटिक फेज करेक्शन ऑफ सिटी भी होगी, देखिए यहाँ अच्छा लग रहा है, सब ठीक है, एकदम दिख रहा है, देखिए फिर उसको स्टैटिक फेज में छोड़ देंगे फॉर द मैचुरेशन ऑफ द स्ट्रेस्ड एंड कॉग्निटिव सोर्स। जो बस स्ट्रेस्ड हुआ है उसको थोड़ा रेस्ट देंगे 4 वीक्स 5 वीक्स 6 वीक्स, जो आपका अपना आईक्यू से देखिए कर सकते हैं। एकदम स्वेलिंग खत्म हो रहा है स्टैटिक फेज, थोड़ा सा एनेस्थेसिया देके विटामिन देके निकाल दिए, निकाल के एकदम सपोर्ट फुट हो जाता है, ड्रेसिंग कर देंगे 3 टैप्स के, उसका प्लास्टिक लगा देंगे, फिर 2 वीक्स बाद उसमें एकदम सॉफ्ट हो जाता है, उसको लगा दीजिए, सूर्य में उसमें चला दीजिए, उससे ही जी
ये करेक्ट करते वक्त ये न्यूट्रल में है,
मॉडल भी ऐसे वाला पैर नहीं आ जाता है, एकदम जादू जैसा है, इससे आएगा ना, जैसे जैसे ही हम चलाएंगे ना
पीछे डिस्ट्रैक्ट होगा तो आगे अपने डॉक्टर
ओके, एक खुलेगा,
हाँ खुलेगा,
फिर इसको क्या करना है, खोल के थोड़ा मैनिपुलेट कर है ना, फिर मान लीजिए उसमें भी नहीं कर रहा है तो यहाँ से रिक्वायर और नॉट रिक्वायर, हमको पेशेंट को ठीक करना है। बहुत लोग कहता है एक टेनेटोमी भी कर देते हैं, कभी कभी पोस्टीरियर टेनेटोमी भी कर देते हैं, ऊपर से वहाँ पे वास्कुलर है, सब कुछ है, इसको तो एकदम 100% कितना करेक्ट इस एज के बच्चा को किए, ठीक हो गया, घर गया, फिर उसको 9 साल के बाद बुलाया, फुल्ली करेक्ट, 28 फुट रहता है, सपोर्ट रहता है, एनएस रहता है, हील देखेगा वेलगस में।
वीडियो बना लिए ना, इन लोग का मोबाइल नंबर ले लो, सबको भेज देना, थोड़ा बहुत रिपीट हो जाएगा स्टूडेंट्स को।
ये सब देखिए स्ट्रक्चर हम इसमें ए यूज करते हैं,
नहीं गया मैंने ये गाड़ी में
फिर मान लीजिए वायर उसको कट भी करता है,
सब सिंपल जो है,
सब छोटा छोटा रेंज से मान लीजिए कि आपको लग रहा है कि समटाइम्स हैंड से नहीं होता है, टफ स्ट्रक्चर ज़्यादा फोर्सफुल नहीं करना, बच्चा केक करेगा तो हटा दे, आगे बढ़े केक या पीछे
हो गया।
इसको हम लोग क्या करते हैं, बच्चा को तकिया लगा कवर डाल देते हैं, बच्चा डरता नहीं। नहीं है ये नहीं है तो हम तो भी लगा देते हैं, बहुत मॉडिफिकेशन कर देते हैं। अच्छा अब बोला कि इन टोइंग फिर टोज होगा तो फुट पैड को रबर से इसे यहाँ कनेक्ट कर देते हैं, और फुट पैड जो होता है परमानेंट होता है, जैसे वेरी इजी इंडिजिनस चीप, सब पैसा इम्प्लांट्स वाला को दीजिएगा तो आप भयानक लेकिन मरीज को भेजिएगा गांव घर में, बहुत इजी हंड्रेड्स की है, बिहारी का वो आदत है,
डिस्ट्रिक्ट लेवल पे यही सक्सेसफुल है, रिजर्व सब तो बड़े सेंटर में
आपका बॉस को बोले कि खिलाइए पिलाइए आप यहाँ की तरफ, खाना चल रहा है,
2 वायर के साथ ये कनेक्शन रखना पड़ेगा, वो यहाँ से किया।
देखिए यही जिग का काम करता है, इसका होल जो है जिग का काम करता है, इसमें डाल बच्चा और फुट में क्या है, पावर टूल नहीं इसमें में लेंगे केवल 1.8 मैक्सिमम, और आराम से देखते हैं हाँ जा रहा है, हम लेटरल टू लेटरल जाएंगे, कोई न्यूरोमस्कुलर धीरे धीरे जाएगा, मान लीजिए के वाई डाइवर्जेंट हो गया, छोटा है ना, इधर से बेंड करके स्ट्रक्चर में डाल देंगे। कभी कभी उसका कैलकुलेशन बहुत अजीब पोजीशन है, इतना जगह नहीं देगा तो डाइवर्जन क्यों आ जाता है। हाँ ऐसे इधर डाल देंगे, इसी पॉइंट से इधर डालेंगे, उसको बेंड करेंगे न्यू हिस्टोजेनेसिस जाइए आइए नहीं कि डिस्ट्रैक्शन कर देंगे, नंबर दे दीजिए, इसको यहीं छोड़ देंगे बस।
छोड़िए अभी बाकी अभी और
अच्छा 700
इंशाल्लाह कर लेंगे।
सर सीटीवी के लिए कोई बुक कोई अच्छी
है ना, साइमंस GW का है, हम पढ़ते थे साइमंस GW का, टर्को विजय का, वो सब साइमंस GW देखे ना, मिला दीजिए बहुत है उसमें। उसके बाद हम बहुत सारा आप इसी में कर रहे हैं क्या, इसी में जिस में PG के लायक था नहीं, तो पांडे जी तो
कम रिसोर्स
चले जाइए दिल्ली के बाद 15 बजे। सर उधर से नहीं।
Ram Chadha is president of IOA. He has been past president of ASSI. He has headed organizations in Mumbai Spine also. And above that, he is a very nice gentleman who is always ready to help you out. Very friendly guy, and whom I know. I am lucky to be in association with him for the last 15 years. Another gentleman, Dr. Abhay Nene, he doesn't need any introduction. You talk about spine, you talk about some rock band, you talk about cycling, or if he is not doing these things and he is not traceable, be sure he might be somewhere in Himalayas. Either cycling, mountaineering, or just doing what he loves to do. So, apart from this, academically he has got a number of papers to his name, and he has been chair of Asia Pacific Spine Organization as well, AO Spine. Apart from these two gentlemen, we have Dr. V.K. Sinha, ex-HOD PMCH, Dr. Rakesh Chaudhary, Dr. Mahesh Prasad, and Dr. Mahesh Kumar, all spine consultants from Patna. So we are here to begin with our spine workshop. We will be focusing on pedicle screw fixation in lumbar spine, which will be followed by lateral mass fixation in cervical spine. So to begin the session, I would like to invite Dr. Ram Chadha, who will brief us regarding pedicle screw fixation in lumbar spine. Thank you.
Thank you very much for your kind words, Dr. Prasad. Dear friends, a lot of my very senior respected colleagues are here, and I also see youngsters who are interested in spine surgery. The commonest and the earliest implant that we put in the spine as spine surgeons is the lumbar pedicle screw. And we move from the lumbar screws to the sacral screws. Then we gather some confidence and go into the thoracic and the cervical spine. I was very brave in the early 90s, and we used to put in pedicle screws, usually 4 of them, because that's all that we had and we could afford. And we used to do a lot of back and front surgeries. This was like an upper lumbar spine where we did the back and front surgery. And unfortunately at that time, we used to do our surgeries only with a lateral view, because that's all that we had. We had X-rays, we didn't have C-arms. So we used to put in these 4 screws. Then on the same sitting, we used to flip the patient and usually do a retroperitoneal and put a large iliac crest graft there. But we would realize over a period of time that we were doing something wrong, and despite the anterior graft, there would be an implant failure. Much later, we realized that it's equally, if not more important, to take an anteroposterior view. And that's when we realized that out of 4 screws, 3 were extrapedicular, and there was only 1 in the pedicle. Having said that, we then moved to using the C-arm, and we started putting in screws, and we started putting in interbody spacers, and we looked back and put our heads together and decided what's right. Was it the right way the first time when we didn't have resources or technology to support us? Or are we doing it better now? We've moved by leaps and bounds today to have not just image intensifiers, but C-arms and O-arms and robots. But the basics of what is being done, how it is being done, and why it is being done is very, very important, and more so in workshops like these. We need to know what exactly is the screw. We need to know how to put it in. And if things go amiss, either with the screw or with the bone into which we are placing the screw, are there ways of salvaging the situation? The screw has a head, a neck, and a body. It may be either a conical or a cylindrical screw. It has a major outer and a minor inner diameter. The difference between the two is called the thread depth. The pitch of the thread is the distance between the crests of two adjacent threads. That's called the pitch. What does pull-out strength depend on? Larger outer diameter, smaller inner diameter, shorter pitch, and bone strength all are necessary to have a good pull-out strength. The morphology of the pedicle also affects. 60% of the screw pull-out of the screw depends not just on how good it is or how stiff it is. In the osteoporotic spine, unfortunately, if the bone quality is poor, especially if the T-score is less than -2.5, you have to be skeptical by placing these implants, and it's always recommended that you build up the quality of bone if it's an elective planned surgery. If it's a traumatic situation, you may use the augment or salvage procedures. I shall talk of later. What's the fatigue strength? After you put it in, can it break? Well, the inner diameter is the most important as far as the fatigue strength is concerned. The neck, the part between the head and the body, is the weakest part. And if you've ever seen screws which are broken, most of them break there. It's the weakest part in the monoaxial screw. And in the polyaxial screw, it's the part, again between the head and the neck, but where the polyaxial part articulates with the rest of the construct. There are different designs. We have now dual screw threads and dual leads and dual threads, all of which we have ways by which the neck is being augmented or strengthened. All these are being done today. As far as technique is concerned, originally when Roy Kamil described it, he went all the way bang straight in. He used to put parallel screws and they went in transped straight. Then to increase the length, increase the convergence to prevent the parallelogram effect, started going more laterally from the outside, converging the two. So we had various points. We had the Gans's point, we had the Roy Kamil point to begin with, then get Steffi's point. So we had various points that we used as we moved outwards to place the screws in. Having said that, a lot depends on how well you place the screw primarily rather than reposition it to get a better image. Convergence of screws by about 30 degrees can increase the pull-out strength as well. Insertion depth, now this is very critical. Initially people said just going past the pedicle is adequate. No, you have to go to 80% or beyond, but should not go bicortical in the lumbar spine because there are vital structures beyond. The one screw that has to be bicortical, if not tricortical, is the sacral screw. Well, what do we do for augmentation? Well, if they're severely osteoporotic, you can use cement, you can use additional hooks or screws and wires, you can use larger screws to occupy most of the pedicle, you can direct them upwards, a lot of them can even go bicortical going outward, it's called the cortical screw which is available now. And having said that, some people even pass two screws in the same way. So in conclusion about the screws, what you need to know is that the outer diameter of the screw determines the pull-out strength, while the inner diameter determines the fatigue strength. While inserting a pedicle screw, the dorsal cortex, the one that you normally go in, a lot of people say you must go all the way down and get it out till you see that huge bony ooze. Avoid it, just identify where the bony ooze is coming from. Because if you do that, you're actually losing the cover of that cortical bone there, and you will have your screw head sinking. So you don't want that. So just identify that point, maybe with a small K-wire or with an initial starter, but don't really go all the way whole hog and see that huge cancerous ooze. If you do that, you're weakening the hold of your screw. Fixation can be augmented, as I mentioned. You should ideally pass your screws converging and going a little bit up towards the disc space, but don't necessarily perforate the disc space, up and in as they say. You must, as I said, not break into the Kefaloid end plate, but don't go all the way caudal, except in thoracic spine where you may choose to do it. Rotational instability can further be improved if you're doing a short segment by using sort of transverse connectors. In the long constructs, transverse connectors don't really matter as far as rotational instability, but they also matter if you're using it to reduce the stress risers and the pre-bending stretch if you're using long constructs as in scoliosis. Please understand that all these things have to be kept in mind as and when you put the screws in. What exactly do the screws do? Well, they basically impale the vertebral body. They connect the posterior to the middle to the anterior column, and they can be used to three-dimensionally control the body. So it's a three-dimensional control over the vertebral body, beginning from posterior to middle to the anterior column. How do you put it in and where do you put it in from? 5 anatomic structures converge, and that's where the force nucleus is, which is the safe passage for the posterior column entry into the anterior column. Is the superior passage, inferior passage via the pars, the lamina, the pedicle, and the TP. All of them meet at that convergent point, and you push the screw in from there. How do you find that point? You go along the pars up to the superior faucet and identify the transverse process and be at the midpoint of the transverse process. That's the convergence of these 3 points, where you will find that small intramedullary means medulla of the pedicle, and push your screw in through that. Is there something else besides the screw? Yes, there has to be a spacer, a rod or a blade which either distracts, compresses, or just positions or holds those screws in place. Conventionally, done in the prone position. In the olden days, open surgery, have your image available, have image intensifier available, have a bone model if you're doing it for the first time. Identify your point of entry. A simple tip, if you're doing L4, L5 stabilization for the first time, where you're doing a fusion procedure, pass the L5 screw first. Why do I say that? Because the L4-5 facet joint can be opened and is a part of the surgery, fusing L4-5. Am I correct? While the L4 screw, you don't open the L3-4 joint. So if you're doing it for the first time, pass the lower screws first, so that you will really open the joint, see it, burn it, because it's a part of your procedure, fusing 4-5, and identifying your points. Having put those screws in, then you will be more comfortable to pass the higher screw, where you will go outside the joint, preserve the joint capsule. You won't open it, because if you open it, you're asking for an adjacent segment disease in the future. Place your C-arm the way you want. You can take AP and lateral views, use an operating microscope if you're comfortable with it. Earlier, people used to drill the initial point of entry. We now just use a particular seeker, probe, or starter, whatever you may want to call. These are K-wires. Get in, get your straight or your curved probe in, whichever one you prefer. Most of us now use something like a Lenke's probe to get in. Having said that, you may choose to tap, you may choose not to tap, that's your personal thing. I usually under tap my screws, that means I use a 1 millimeter lesser tap, more to confirm the outer surface of my hole that I've made. Is my passage safe enough? So these are the various points that I spoke of, from medial to lateral, which is from right coming to right up to the dance point, and you can go through even the Steffi's point in there and go all the way in. Having said that, do you tap? As I said, I always tap them. I used to earlier use a lot of monoaxial screws, especially for my high-grade prosthesis, but you could choose to use the more surgeon-friendly polyaxial screw. It's easier, it gets mono once you put it in. These are the points that you will identify, a midpoint of the transverse processes, a transverse line going through the transverse processes, and a vertical line dropping on the outer side of the facet joint. Where the two meet, that's the point that is your point of entry. A lot of people use K-wires. We used to use candlesticks, as we call them, which were K-wires with a surface coating of a small plastic so that you don't injure your gloves. And we had a fixed length of 30 millimeters that we used in the front, so we also knew how much we were going in. Having said that, we used to knock these in, then use the starter owl, then use a scored probe which told us whether we have 30, 35, 40 millimeters in. Having done that, Initially, when we didn't have the C-arm, we used to use this toggle test, which is I used to put my instrument in and then gently tap it on one side, medial to lateral, tap it superior to inferior, and if it came back to its original position, that means it's not perforating. This was a very old way of doing it. Today you have the C-arm, and you should actually not risk it because this may cause a neural injury even if you are not doing it. Then use your fine Baltic probes, identify the integrity of the passage that you've created. Use a tap, which I do. You may choose not to use, you use self-tapping screws. I under tap by 1 millimeter. Check AP lateral, and if in doubt, also check the oblique view. As I said, all screws up to L5 are not bicortical. S1 by choice is bi or tricortical. Thoracic spine, the pedicle is in the upper 1/3 and goes downwards. Lumbar spine, it's in the middle 2/3 and can go straight. So remember this, thoracic spine is from up slightly downwards, when the lumbar spine goes all the way parallel to the superior end. Sacral screws should be bicortical, other screws should be short of bicortical. Contour the rods once you put your screws in. If you are doing it open, you may choose to do the decompression first or may choose to put the screws in first. Most people today put the screws in first. Very few do a decompression. I still do a decompression in the high-grade disthesis because in the high-grade disthesis I want to identify where my nerve root is going. And if they are congenital disthesis, I would like to find out whether I have any root anomalies so that if I can see them, decompress them and identify. A lot of these pedicles of the L5 are very, very aplastic and small in these constitutionally sort of congenital or deformities where we need to identify the complete pedicle before trying to put it in. Otherwise, we may cause an iatrogenic nerve injury. Having said that, I always look for the traversing and the exiting roots. I try and look for any root anomalies and I complete my interbody support. I'm not talking interbody, but remember that these screws are not just implants, but they also work like instruments at times and should be very gently used as instruments. I do not distract on screws without opening my disc space. A lot of people distract and the screws, if you are doing that and heavily loading your screws, you are weakening the hole. So actually remove the disc out and then use it as a placement rather than a true instrument. It's an implant, it's not an instrument. Don't use it like an instrument to distract. Then once you put your spacer in, you can use it gently to compress at the rear. High-grade listhesis or a sort of light listhesis, the screws would be in, you would put your graft in first, then you put the graft in further, then you push the spacer in, then you use a rod reducer and get it back. This is how most of these surgeries are done. If you have a high-grade spondy, what do? Well, you don't need to correct all of them, a few of them you would. Identify on the MRI. I show this in all my pedicle screw talks. That is what you need to see on the MRI. Your MRI guy is not going to report it. What you see there on the left root is a root anomaly. It's a conjoint root. Can you see that? You see that there is a very clear right-sided nerve root, but the left side is like this huge ducts, or there is a continuity. And those are roots where if you put your screw in, inadvertently you may cause a neural injury. So be very, very sure of what you're doing and then go ahead with that. Having said that, we always check all these. You must check that on table you have your rod reducers, you have your rod benders, you have your vice grips, you have all the instruments on board. Usually take incisions, there will always be a fascicle bleeder that you need to find out and coagulate, especially in the open procedures. Look for these dual roots. Unless you know that they exist, you will not look for them, and if you don't look for them, you may actually injure one of them by pushing your screws in. Identify them. As I said, I use my candlesticks, I go in, I put my screws in, I do a compression distraction maneuver, that's in the distraction phase, that's in the compression phase, that's my rod reducer, and that's my rod holder. Come together. After putting your cages in, you finally can get a complete reduction. Protect the roots with gel foam, put a drain. I always put a drain in these open surgeries when I do them open. And I put my spacer in and try and rotate it to the front. Use the screws to compress the rod, verify the roots, put gel foam bone wax. Sometimes you have to give them DVT prophylaxis and log rolling. At times, if it's a high-grade list, you may have to post-operatively do a little bit of flexion at the hip and the knee and keep them from pain relief. Sacral screw, just a mention, please understand that sacrum, unlike the other vertebrae, is a hollow bone. It's like a long bone. It has two cortices, so you need a bicortical purchase, and the trajectory is usually challenged because of the muscles which are there, and you tend to go straight while you actually have to go medial. So you may either take a Wilsey's approach to pass them, or you may take a longer incision and push them from lateral to medial. And there are important structures which need to be looked at. Something commonly missed is the fact that you go to the sacrum and hit the L5 nerve root in front. Be very, very careful. If you are putting a sacral screw straight, you may get a post-operative L5 neurological deficit, because the screw has not hit the S1 nerve root, but has hit the L5 root in front of the sacrum. There are also vascular injuries that could occur if you go too much in the front. So always study, if you are putting an L5 and S1 screw, as to what is where. Are you still having the aorta continuing, or is the bifurcation, common iliac, or what is happening? Study that and plan your screws suitably. We have S1, S2 and sacroiliac screws. The S1 screws are the standard screws that we put in, which are bicortical, which go from there all the way in medially, angulate them medially. These are the commonly done ones. At times, as salvage or additional screws, you may have to put S2 or S2 LR screws. Go between the S1 and S2 and go outward. Just like a medial screw which goes bicortical or tricortical as the S1 screw, the S2 LR screw goes from the medial end of the S1 dorsal foramen and upwards. And if you will see on the next image, this is where we end up going, right there, in this direction. So they are going up and in. So that is the point where it goes, but it doesn't go across the sacroiliac joint. There's another screw that goes across the sacroiliac joint. This is just the S2 LR screw, and that's called the S2 LR iliac screw, which goes from a similar yet outer point, and you can go much across the SI joint and into the ilium. These are used in long construct, especially scoliosis. They may be used on one side or both sides. And finally, besides the S2 LR, there are just long iliac screws that you may put in, or plain iliac screws which go in through or just next to the posterior superior iliac spine all the way into the ilium. Here you may use a Chopin plate, or you may use a connector in addition, or contour your rod, whichever way you want, to add additional stability, used in osteoporotic bones and in long scoliotic situations. Having said that, there is also a salvage or a procedure by which you can do a high-grade in situ fixation of a listhesis using a delta frame, where you can go from the sacrum across the L5-S1 into the L5 space. So this is not commonly done, but can be done for high-grade listhesis in situ fixations, and is another way of putting the same sacral screw into that. I've shown you all the types of lumbosacral screws that can be done. But please understand that in spine surgery, you need to tread cautiously. For things are changing as we talk. What's state of the art today is history tomorrow, and obsolete the day after. Do not get market driven or techno savvy. Don't get carried away. Do what works best in your hands. So please understand, it's what is in between the 2 years that is more important rather than what is coming to the years. Always know why you're doing something before knowing how and what is to be done. If you're doing something like this, which you don't know why, sooner or later you may end up like this. So be extremely careful that these so-called single screws in the lumbar spine cannot stand the torsional loads of the lumbar spine or the bending forces, and you properly need a good transpedicular hold. Why do I say all this? When I say this, because the more you know, the less confident you are likely to be. Experts know just how much they don't know. They tend to underestimate their ability, but it's easy to be overconfident when you only have a simple idea of how things are. This is now the Dunning-Kruger effect. Try not to mistake the cautiousness of experts as a lack of understanding, not to give such credence to lay people who appear confident but have only superficial knowledge. And I quote Bertrand Russell, "The whole problem with the world is that fools and fanatics are so certain of themselves, yet wiser people so full of doubts." Confidence rises when you have very little knowledge, but then it ebbs, and then you finally reach a stage where you know that you don't know, and you also know what you know. Good results will come from experience, and experience will only come from bad results. I thank you all for a very, very patient hearing.
Sir,
Thank you, sir, for that elaborate talk. It was very well made, and so many things even I could learn from those slides. So the next thing in learning should be, after listening to the experts, we should actually have a practice it on SAW models. Then your learning curve, it should be on academic models, then under some experts guidance, and then you should go for the real thing. So for the next stage, we'll be doing pedicle screw fixation on sawbone models, for which we have sponsors from Medtronic and Geon company. So I would request all the delegates to be on the table.
Finish on the top and then do both together.
Whatever you're comfortable. So then we'll have a break and so Dr. Nene will give us the next talk on cervical lateral mass screw fixation.
So pedicle screws have come a long way, and I think all of us here sitting here is like, when I was sitting there, I saw so many seniors in the house, and I said, what इन लोगों को मैं क्या screw करने सिखाने वाला हूँ, because बाप को सिखाएगा guys like that. But cervical pedicle screw and cervical lateral mass screws have been somehow left out of the mainstream, and that's unfortunate because it's one of the easiest screws to actually pass. If you see in the lumbar spine, you just heard from Ram, there's so many difficulties that you face. In the cervical spine, barring the fact that it's the cervical spine which freaks you out, there's no difficulty because it's the only problem here is problem of too little bone. So if you see the place where you're putting the screw is a very, very small area, and the availability of bone is very little. I mean, if you just leave aside the big red and the big yellow, this is all that you have. So if you think about it, you're starting your screw away from the yellow, that's the nerve, and the red, which is the vertebral artery, and then you're going further away. So the problem is that the bone is so little that your bone screw is not going to get a hold. So remember that this is not a dangerous procedure. It's one of the safest procedures in all the thoracic spine, lumbar, sacral, etc. because there's no danger there. You're starting away from the danger and you're going further away. You're not getting into the danger. In the lumbar spine, you're getting into the danger zone. In the thoracic, you're jolly well getting into the danger zone. But in the cervical spine, you're running away from the danger zone. So if you can start right, you go. But the problem is there's too little bone to hold, and these are often, they turn out to be like Mickey Mouse screws. Alright? So you need to use these bipolar cautery to dissect, because small venous bleeders get, it's an area of infamiliarity for us. We are not familiar with this area. So in that area, it's good to go a bit slow, dissect, but you have to eventually see that lateral mass dropping down. Alright, I hope that's clear. Now, so the exposure is the key, and you want to expose the entire lateral mass. This is what the lateral mass looks like. So it's like in your head, it should be just like one cylinder, except it's like a cylinder, but the cylinder has a roof and a floor that is diagonal. It's not a straight roof. So the roof is a facet joint, and the superior articular process, and the floor is an inferior articular process. So it's a cylinder with a roof and bottom that's like obliquely placed. And if you can, picture that, this is defining the lateral mass. So once you're on the lateral mass, use a cautery boldly. That's the lamina, and this is the lateral mass. To identify the superior edge of the lateral mass, which is indeed the facet joint, the lateral edge, as we described, where the lateral mass drops down, and then the inferior edge, which is the inferior facet joint. What would be the medial edge? Anyone? The medial edge of spinolaminar cleft, right? The spinolaminar junction, where the spinous process becomes the lamina, is really where the medial edge of the lateral mass. And we'll see it on this, on the bone model. Now, once you've defined this lateral mass, it just looks like a square in front of you. Actually, it's a cylinder, but one dimension looks like a square. You look for the midpoint of this square, and it's quite easy, right? So once you have the midpoint, if you look at this diagram, this correlates what the surgeon sees. This is a PA view. The surgeon is looking at the midline, and this is the lateral mass. The midpoint coincides to the outer edge of the vertebral foramen. So all the time in your head as a surgeon, you're thinking vertebral artery, vertebral artery, vertebral artery, right? That's what's freaking you out. The minute your entry point is on the midpoint, you're starting away from the vertebral artery, and then you're going further lateral. So you're totally safe. Is that okay? So if you can identify the lateral mass and point to the midpoint, you're safe. You're outside the zone of discomfort, and that's the midpoint there. The problem is that if you start from here, you will get a very little amount of bone to hold, as you can imagine. Just use common sense and tell me, if you have to grab maximum bone here, you want to start from here and finish there. You don't want to start from here and finish here. Then the screw has very little hold, right? So so when you're in the start of your practice, you may want to use this as your entry point. But as you get more and more experience, thanks for the music, folks. As you get more and more experience, you start getting the entry point more and more medial. The more medial you go, the more oblique your screw is going to get, so the longer screw you get, so the better the bone hold. However, there's a worry, because the more medial you go, the more you're transgressing on this safe zone. So if you're not fully oblique, you may get into the vertebral foramen. So you need guts to move your entry point from here to here, but if you have those guts and you have the skill, you can get a better screw, right? So that's one. The other is, how about superior and inferior? If I got it from here to here, I got this length. If I got it from here to here, I would get that length. I would get a much better length. So the moment I start going inferiorly, so this is where the standard midline or a midpoint entry point would be. It's a small hold on the lateral mass. Incidentally, this is the lateral mass. But as I go inferior, I'm going to get a much longer hold. So an expert surgeon will shift his entry point medial and inferior to the midpoint. A novice will start at the midpoint. Both is okay. Remember, you've got to be safe, but try to up your game by getting getting it somewhere here, maybe in the midpoint of the inferior and medial quadrant. That might be a safe place to be. The problem is that the more inferior you go, the longer the screw you get, but it's hitting straight at the nerve root. So that's pointing straight at the, so if you get it slightly long, you may hit the nerve root, and I have had to revise a screw because it caused a nerve root deficit post-op, okay. So this would be my entry point, not absolutely in the midpoint, but slightly inferomedial to the entry point. And the facet joints are your saviors. The facet joints, once it's exposed, it gives you the angle. So if you just stay in line with the facet, you're normally fine. If you're clever, you may actually go and try to cut that facet. So don't stay parallel, try to gain on length by cutting the facet and go slightly, aiming for the outer cortex. And so on the axial plane, this is what the direction should be like, not this. So the minute your direction is in line with the lamina, which is in fact restricted by this bifid spinous process, like you want to get it as slopey as possible, but this gets in the way, and in the way that's a good, something that holds you down. That's the kind of entry point you want to get. So here's once again on the model, we're defining the midpoint, and we're showing you that's where the entry point should be. And the trajectory should try to take the owl all the way to that corner, and one of the easy ways to do that, and you'll hear us saying that again and again, is to try and match the owl with the inferior spinous process. This becomes a good landmark. So if the owl drops down and touches the inferior spinous process, you normally get it right, and that becomes your limitation of lateralization. You can't take it any further lateral. So I hope that's clear. So here's on the surgical side, the lateral mass is nicely exposed. This is the inferior facet joint, this is the superior facet joint. This will be the midpoint. Okay, so the surgeon is getting right into the midpoint of the lateral mass here and creating a little trough, because as you can imagine, you don't want this owl to slip. Once the trough is created, you use a sharp owl and start going laterally. You can use a little drill also. You can even use a burr and make that little hole, because you just have one chance. If you do that more than once, the lateral mass just explodes on you and then you're done. And with a very gentle movement, you go forward. But this has to be a bicortical screw, so you should feel that give way. And unless you get the outer cortex, you may not, you may not have a good screw in place. Now, after this, tapping becomes important. Once again, for the same reason, that bone is really small. So if your screw is slightly wobbly, which means that there's some torque when you're putting the screw in, it may shatter the lateral mass. So at least tap the entry of your screw. Use a tap to get the screw to guide yourself in, and then go across. Make sure that your ballpoint probe has pierced the other side. So you have a bicortical screw in place, and that's how a good screw would look at the end. And just one little bit on, as you go lower down, remember the entire mass of bone that carries the vertebral foramen starts to shift more laterally. So it's more medial in the upper spine, it's more lateral in the lower spine. So you want to err a bit laterally when you're in the lower spine. And in fact, I'm going to take one step up and say that in the lower spine you could actually pass cervical pedicle screws, because now you've got a much bigger window here compared to the upper spine. So cervical pedicle screw uses a much better bone, and in fact you can get a really long screw. And in fact, if you're doing a laminectomy, as shown here, you can literally use a little probe and feel the pedicle and pass these screws open, and it's not as difficult as people make it out to be. If you've done a wide laminectomy, feel the inside of the pedicle and pass the screw. It's a much better screw than the lateral mass screw. After this, the screw heads have to be placed in such a way that they don't get in the way of your laminectomy. The best way to do the cervical laminectomy is using a drill and creating 2 troughs. Once these troughs are created, you thin down the bone, so the use of your ronger is a very light hand. You're not using a heavy fisted hand, and you can then start nibbling away with the ronger, like a 1 number or a 2 number ronger, after creating 2 troughs, one on this side and one on the other side. And then eventually feel the, after this, it's a good idea to put the rod in, because the rod is a bit of a fiddle. So put the rod before you actually take the lamina off. While putting the rod, make sure that the lordosis is correct, because the rod may be bent, but remember it's a very flimsy, I think 2 or 3.5 mm rod. So it's not at all a strong rod, so it will just bend under pressure. So you want to give it a nice lordosis and fix the rod in lordosis, and then peel out the lamina in the standard manner. If you like to do a laminoplasty, you could just leave it there, but it's a crappy procedure. I would not recommend anyone to do a laminoplasty here. And once the lamina is out, you're done. So remember, the only places that can, get back at you, one is when the drill has gone into the nerve root, so you've taken a much longer screw. I'm not totally, agreeable with this sentence that keep it 2 millimeters shorter. I like the screw to be into the cortex, so it has to be exactly in terms of length. If you're 2 mm shorter, the pull-out is much, much worse. But you don't want it to be too long. And then medial angulation you don't want to get because there's a vertebral artery. So this is how a good screw would look in the end. And having said all this, it's seriously not the gold standard for cervical fixation. These are Mickey Mouse screws. They don't have good pull-out strength. So after this, you got to up your game to start putting cervical pedicle screws, or you should have other forms of cervical fixation available like sublaminar wires also. But make sure that whatever you do is safe in your hand. Thank you.
So if there are any questions, we have all the faculties over here. They will be very much happy to clear those doubts. Questions before we go on for hands-on practice.
How many people pass lumbar pedicle screws in the group? Put your hands up. Not a lot. And cervical?
Cervical lateral mass.
Not many.
One thing about cervical lateral mass, it gives you only one chance. It's very easy to put, but it gives you only one chance. You have to be very sure that you don't blow the entry point. So the entry point, when you make, it has to be first perpendicular to it, perpendicular to the surface, and then you have to angulate it. It's always at an angle that we put. But if we start with that angle, that entry point is going to blow, it can actually get expanded. So the point is, whatever entry point we have chosen, whether it is at midline or medial to the midline or medial and inferior to the midline, you first go perpendicular with the burr or with your entry point, and then try to slightly expand it and then make an angle and then proceed.
Can someone find a fault in that X-ray? The last right top corner. Which screw is bad in that? If you understood the lecture, you'll be able to point that screw out. The lower, the second from the lower is getting into the foramen. Great. So that's the one that could be hitting a nerve root. Sometimes it's a bit lateral, so it doesn't hit you right away. But you want to check this on an X-ray before you close, and if it is there, you just pull it back a little. Dr. Ram, one question: What happens if you get a pedicle blowout? What's your salvage plan to get to fix a pedicle blowout?
We have instruments.
Pedicle blowout is if you've actually gone into the pedicle perfectly and yet you've blown it out, that means the quality of your bone was poor. In which case you have to actually do away with that pedicle and either put a sublaminar wire or go to the next pedicle. But if you've gone into a pedicle and cut out, so if you've cut out superiorly or laterally, you've still not caused severe damage and you should re-attempt to pass that. But if you cut out medially and inferiorly, then first verify the neurological damage that you caused, recheck and then place whatever implant you want, either a lesser or in a different direction. Please understand that most of our pedicles actually are large enough to take a correct screw. And you can replace the screw. But if you've blown it out completely and the bone quality is poor, when you actually go to another modality, that is you hold something around the transverse process or go translaminar or you do something else, but you can't put it again in a completely blown out pedicle.
Do you pass a screw first and then do a laminectomy, or vice versa? What's your...
And that's exactly what I answered. In my high-grade spondylolisthesis, earlier I used to do all decompressions first and then pass my screws, where I used to identify that my screw is always right. Today I realize that in the standard cases where I don't deal with nerve root anomalies as commonly, I have no problem passing my screws and then doing my decompression. But for the initial high-grade listhesis and complex deformities, have a look at the inner wall of the pedicle and then pass your screw.
Also, I would like to point out that the learning curve is actually steep. So whenever we proceed, one should actually see the K-wires in AP as well as in lateral view. And what is to be seen is, in AP you check out the whole border of the pedicle. You see to it that your wire, when it crosses the medial wall of the pedicle, in lateral view it should be in the body. Are you getting me? So in lateral view, there is a pedicle and then the body comes. So if your wire is already, it is just at the tip, at the junction of the body and the pedicle in lateral view, and in AP it is well beyond the medial wall of the pedicle, that means you have done a medial perforation. It's a three-dimensional structure, so you should understand that medial wall of the pedicle in AP view, the wire has to be away from the medial wall till you have not reached the body. If you have reached the body, it can be beyond that. And if you have reached the body, still the medial wall of the pedicle has not been crossed by a K-wire, that means your wire is actually directed laterally. Then you have to aim, take out the wires, aim more medially, and then that's how you correct it. Every time you check out all the 5 walls, once you have made a hole, check all the 5 walls. The medial, lateral, the superior, the inferior, and the floor. We need to check all these 5 walls because floor is equally important. Even there are papers that you put bicortical screws, but if you actually try to perforate with the all, you are actually inviting trouble. So in an osteoporotic bone, the floor gets perforated just by the screw. It's acceptable if 1 or 2 millimeter, it's beyond the wall. But in a normal young adult, to try to perforate it's like inviting trouble, because there has been cases where the vascular injury has been noted. Anything else? Any tips?
No. My question to you, would you do CT scans to see the size of the pedicle before passing screws? What's your opinion on doing pre-op CTs?
Usually I don't do in my practice, it's more of eyeballing, and most of the times we get away. So I check it on the x-rays, pre-op x-rays, which is a must, and it's a must for each and every case that I do. Secondly, I usually use this 2 millimeter wire and 2.5 millimeter wire. So one side it's a smaller diameter wire, the other side is larger. But with that wire, when it's in the pedicle, it gives me an idea about the diameter of the pedicle. So if it's snugly fitting, that 2 millimeter or 2.5 millimeter, I know it's not going to be 6.5 screw. Also in thoracic, I never go for 6.5. In lumbar, I aim for 6.5 screws. Your experience about this?
My take is that I always concentrate more on a good AP view. All of us understand that thoracic spine screws are passed in AP view, but I stick my neck out and say that I prefer to pass my lumbar spine screws also in the AP view. The AP view is far more important than the lumbar the lateral view. The lateral view only tells us the length of the screw. It's the AP view which decides your direction, your trajectory, everything, and the safety. So I think the AP is more critical than the lateral. All through.
So in AP you read the pedicle.
Everything. You can actually do a complete surgery naked. Yeah.
So, but I differ on that. Lateral is equally important because as I told, the medial lateral trajectory we want to see.
Medial lateral trajectory is on the AP view.
No. If your wire is more.
Medial lateral trajectory is on the AP view.
No, it's on AP, but if my wire is more inside.
Only thing that you see on the lateral view is your depth and how beautiful your post-op X-ray looks. Which again we do differ, because he doesn't care how it looks and I'm a little bit finicky about how it looks.
That's all. I think I am in between both of you.
No, I respect you for that, because truthfully it doesn't matter how the X-ray looks, it should work. That's more important. I am with him, I agree with what he says.
So the hold is the most important thing, and the more you fiddle around, the more likely, even if the angle, your screwdriver and the screw, if it's not aligned, while putting the screws, it's going to wobble around. So that's further going to make your hole bigger than what it should be. So all these small things, they matter. And don't fiddle too much while putting screws, because if your construct to begin with is not perfect, down the line the patient is at the risk of implant failure.
Any tips on freehand pedicle screw?
Freehand usually means what I do is, suppose the CM is not working or it comes off, that's the only time I go for freehand. You should be very careful. You see where the so points remains the same. The only thing you should be worried about is your directions. So in that, if you start your interpoint, see to it that the first till you don't pass almost 20 or 25 millimeters of your probe, you don't cross the pass. That's one point. Secondly, you have to feel all the 5 walls. You should be very careful with that. The usual direction of the screw is perpendicular or it's parallel to the end plate. And if you see, the lamina is slightly slanting backwards. So if this is the body, the upper end plate of the body, the lamina is slightly angulated by 10 to 15 degrees. So when you take the interpoint, I usually see to it that I am almost 10 to 15 degrees pointed upward as compared to the lamina. The other reference for my medial angulation and medial angulation will be the spinous process. So it goes on converging from L1 to L5. It goes on converging. You can roughly say around 20 degrees for L1 and go on increasing by 4 degrees to each. So that's the convergence for medial angulation. For L4 vertebrae, it's most of the time the screw in lateral view, it is almost perpendicular to the floor. And as you go upwards, you go on increasing directing it superiorly. And if you see this angulation is actually around 10 to 15 degrees so if I act to the angle of the lamina. So these 2-3 points I keep in mind while putting freehand technique.
Dr. Ram, when you're putting your owl in and you pull it out and CSF comes out of the hole, what's your next strategy or what would you suggest we do?
First thing I do is I pray.
Pray, yeah.
Yeah, I pray first, yeah. Because if CSF comes out, you should pray first. Having done that, what I do is that I would immediately stop that with either a gel foam or with gel foam plus bone wax, and then go onto the medial side to see, do a decompression if I have not yet done it, to see what exactly I have done. If I have done something which is repairable, then I just pack that part again and then continue with my surgery and address that later. If I have impaired the root completely, that means I have missed a conjoint root or something earlier, then I will not attempt that pedicle removal. So these are the 2 things. I will see what is the cause of this and then remedy to it. Usually it would be that I have gone to medial and I identify it, I pack it, and then under vision put my screw a little bit more laterally and a little bit more superior, because that's the 2 places where I can get CSF, medial and inferior. Usually medial, less likely. So that's the way I would address it.
And what if your pedicle part just blushes with a lot of blood? Sometimes it's called like a blush.
Yeah.
So from the hole you made, there's a lot of bleeding coming out.
Yeah.
Is worried that you made something bad or?
No, I am not worried when I get blood through the pedicle. I am not worried.
It's expected, isn't it?
Yeah. But one point I would like to add what he said, and I have learned that by experience. It's not mentioned in books. It's what I call cheating the pedicle. What I'm trying to tell you is just listen to what I do and hear me out. Suppose your C-arm is not working too well. That is what he says, freehand technique. You got your point of entry, which is usually not a mistake that you make. The mistake you make is when you're going in, you may go inferiorly and breach the pedicle inferiorly, or you may breach the pedicle medially. These are not good breaches. A superior and a lateral breach, well, it's okay, they don't do much harm. What I do in this situation where I don't know where I'm going,
is that after I've gone in about 5 millimeters or 7 millimeters, which is safe, I've not perforated anything at that stage. I use, if I'm going to put a 6.5 pedicle screw later, I pick up a 4.5 millimeter tap. Hear what I'm saying very carefully. I pick up a 4.5 millimeter tap and I finger tap. Please understand, if you put that tap in there and don't do this, but just do this, the tap will never break the pedicle wall. The tap will find a path of its own, which will be within the confines of the pedicle. Hear what I am trying to say. The path the tap will not break the pedicle wall. Use it like this. Don't push it in. Let it go the way it goes. The tap is something which cuts its own threads. Just with your finger, let the tap go in. The tap will respect the medial border, will respect the inferior border, and will go in. Then replace that with a 5.5 millimeter tap and pass it. Try it the next time you stuck.
Yes, so this thing I have learned from you at Lilavati and still I practice whenever I get stuck, sir. Other point is Dr. Name. Suppose you have done screw fixation very well, screw fixation seen on C-arm, and just after decompression you are checking the exiting route, you see that that thread of the screw is seen. So what will be your reaction to it?
So it's important to replace it. Because if you can, so what happens is after decompression you see that the thread seen on the, so invariably when you're passing the screw you know that you're probably erred slightly inferior, but you say chalta hai and you move on. And after the decompression you want to check it. If you don't want to check it, you'll never check it and you'll never see it. So it's important that if there's some screw that's a bit dodgy, after decompression you follow the pedicle down, or you can use a pen field and feel the sound. Your truck sound means your the threads are out. And those will keep irritating the nerve root, and instead of going back in later, you should have the patience to extend your surgery by 20 minutes more, and undo the construct on that side, take the screw out, put in a new screw. Otherwise, even if you have no neurology, you may get, you may get irritation of the nerve root. So I think you can't put a gel foam there and say that this is going to protect my nerve root.
Yeah. So that gel foam additional fat usually doesn't work. And if you have done sufficient number of screws, and one finder you think that there is some doubt, yes, screw thoda aage piche ja raha hai, believe me, 100% times it is actually wrong. So if you have doubt that something is wrong after having sufficient experience, the thing is actually wrong, that's why you have this. Otherwise, it's not, you will be confident wrong. And all this thing, exercise is like checking all the walls, checking it from C-arm, both use AP lateral. It is just for that one screw. It is only for that one screw which in your lifetime of, or maybe 500 or 1000 screws, which is actually going to be the bad screw, which is going to earn a bad name to you, or going to spoil some of your patient. So that one screw of that 1000 or 2000, which is going to be the wrong screw, for that we have to do all this exercise and do it again and again, because one screw may be wrong in your career, but for that patient it might be one foot drop. It might be something bad also. Okay, so take all the precautions, and if you have some more questions to be asked, please ask, otherwise we will start with the answer.
Yeah. What is the tips and tricks for putting the screw in the upper dorsal spine? Because I usually encounter on the lateral view, the scapula and the shoulder is hindering my lateral view. What is the way to come out for the lateral view position?
AP view is enough to pass the thoracic screw. In fact, the AP view shows 95% of the thing that you need to do. The lateral view is only to check the depth. Thoracic screw में 25, 30 या 35 होगा, उसके ऊपर नहीं होगा, और वो आप मेजर कर सकते हैं. अगर आप AP व्यू में सही हैं, तो आप lateral व्यू में सही हैं. उसकी आप फिक्र मत करिए. Just that you to remember that when the thoracic spine is like this, which means if you're D1 to D4, you will be going downward. On the left of the patient, your screws will be like this. D4 to D8, they'll be almost straight, and D9, 10, 11, they will be like this. Are you understanding what I'm saying? There's a huge thoracic guidance. So that's the way that you go. And yes, high thoracic screws, none of us see the lateral.
It's never seen.
So if you're seeing the lateral, you're the best young in the world.
Yes, sir.
And one question, sir. It is one of question in my mind. if a case with a burst fracture comes with us and we are fixing it. In one conference I heard there is no need of decompression by laminectomy, and someone says that you must have the decompression because there is cold compression. Just for the explanation to the patient, when he has the MRI in the next time, डॉक्टर साहब ने तो ये नर्व को दबाया हटाया ही नहीं, बाद में दूसरे डॉक्टर ने कहा कि साहब ये तो नस दवाई हुआ है। तो मेरा ये जानना कॉमन हाउस से आप एक्सपर्ट पर्सन है, तो शुड आई डू दी डिकम्प्रेशन आफ्टर द फिक्सेशन और नॉट, as in case of the burst fracture in front?
So I will answer this in very short one. Literature does not say that decompression is mandatory, and the results of decompression versus indirect decompression, direct and indirect, while using just the positioning of the listing in fresh fractures, has similar results. So literature doesn't say that you have to decompress. That's one answer to it. So you may, on clinical grounds, decide to do it or not do it. Now coming to the other question, if doctor साहब कहते हैं, so that is something that we have to understand. Medical jousting is something that we have to avoid. तो वो अगर हमको एक दूसरे की बदनामी करनी है तो हम कुछ भी कर सकते हैं, वो हमको सीखना पड़ेगा कि नहीं करनी है सर। तो ये एक चीज हमें समझनी है कि अगर वो दूसरी बात सर अगर डिकम्प्रेशन किया भी तो सर अल्टीमेटली हु कंप्लेन्स? द पेशेंट हु हैज नॉट फेल्ट बेटर, and the patient who has not felt better is somebody who is unhappy because somebody told him that you could have become better. If you were the operating surgeon and you told him that you can become better, then you are erroneous in your decision. You have to tell him कि जो है ज़्यादा से ज़्यादा उसको हम प्रिजर्व कर सकते हैं, जो है वो आपको बोनस है, वो किसी और के हाथ में है, हमारे हाथ में नहीं है। कहानी खत्म हो जाती है सर। अपनी काबिलियत वहीं तक रखिए, उसके ऊपर मत जाइए।
Also, if there is dural tears and other things, you might actually end up having a CS leak.
Yes.
Because many times it is not suturable. So opening up invites other problems also. And remember, the highest rate of infection in spine is actually in trauma cases. Because what we are seeing is actually the cord and the bones, but the soft tissue decatarization, that is of most importance. So infection higher percentage is seen in trauma cases. So if you open up things, the CSF, you can't suture the dura, and God forbid there is infection, the patient will actually end up in problem.
So it is better to leave it as
because the injury occurs at the time of the trauma.
But there are two places where you have to decompress. दोबारा मत पूछना.
Yeah.
One is partial neurology.
Partial neurology.
If the patient has partial neurology and radiology decompression, if you don't decompress, you are at fault. Number two is lumbar spine. In the lumbar spine, if you don't decompress, you may even one root could have been saved. So the lumbar spine has a great propensity of recovery after decompression, and you end up having lumbar canal stenosis, which is a total nil neuro patient after you fix. So lumbar spine, partial neurology, you must decompress. 1 minute. If I am the patient, I am going to ask my doctor to decompress me, even if I have got total para. And that's the thing I follow. That I don't want to be with zero neurology and a compressed cord and saying that literature says that it doesn't work. I want my cord to be opened by Baki Ram Bharose. So I'm going to slightly differ with my colleagues, and if there's a neurology with compression, I would want my surgeon to decompress me. I don't be left for the next 20 years of my life paraplegic knowing that there's a cord that's been compressed behind.
So what is the message of the host to have to be open the cord, open decompression of the cord or not?
Sir, by choice, wherever there is radiological cord compression with clinical correlation, we should decompress. There is no discussion on that. He asked, what does literature say and what do other people say? So my answer was to those points. Literature does not say necessarily that one is superior to the other, but we all know that at the bottom of our heart, if there is radiological compression and incomplete neurology, we must do a proper decompression. And I am one of those madmen who does back and front at times, just because it's an incomplete neurology, and I don't think I can do a good enough job from behind, so I go from the front and decompress. So, and I totally agree with what Abhay says, that what you can do the first time is the best time. So if it means doing back and front, doing everything, do the whole work. Don't stop, don't say कि ये देखेंगे.
Sir.
Most of the experts have told you so many things, and so many discussion might have confused you. Might have, I don't know. So my suggestion is regarding fixation. Only few things. Number one, whatever segment you are going to fix, you must see the diagram before going in the what is the inclination, what is it like, and everything. And you must do it mentally, that what will be the deviation of the guide wire or whatever you say the screw from the midline and from the superior end plate or the inferior end plate. And say in upper that as we told you, what are the inclinations. If you just have a mental figure just before going into the OT, I think you will not mistake. The second thing is that the whole diagram should be very much three-dimensionally clear in your mind. What is the midplane of the spine? If you know the midplane of the spine, and if you are deviating a little bit outer, then you know the angle and you know this thing. And this is strictly true, the lateral do check, that is for the beautiful, sir, how much, distance is there from the end plate or the lower end plate or the upper end plate. Otherwise, most of the things can be done by the anterior, APQ. That's one thing. And it is better to have, if you are at all interested in the spine, you must have the complete spine, the bone model, the real bone. And again, you must take it apart from the diagram before going to the T to actually see the vertebrae, and perhaps you will be much more confident and doing the operation. This little, suggestions. But what will happen, and when it's a more common sense, of course, the CSF building, and I am not going into details, many experts have told you. The second thing is what Dr. Prasid said. This debate is going right from the beginning. Whether you are stabilizing the spine or whether the aim of your spinal surgery is decompression. I think there are many advocates, and I have faced many people in conferences who said, no decompression, only this. But I think a balanced view has come out from both the experts. I think the MRI will whisper you in your ear that you must decompress. And why not do decompress once you have stabilized it? Regarding thoracic spine, he has said, thoracic spine fixation, because it is almost stabilized by your thoracic case. So you need not always venture unnecessarily in the thoracic spine. And only recently I tell you, just that a patient came to me, young patient, say about 30 years, and he has thoracic spine injury. The vertebrae were like this. There was only, say, 25% contact between the two. The neurology was complete. There was no sensory loss, no visceral loss, no motor loss. Can you imagine how difficult it was to make the decision? If at all I venture into this area, something happens to it, will go to my head. And if I don't operate, and something happens later on, then again I will be put to blame. But take it from me, and I don't suggest that you should follow this blindly. You must calculate all the factors. I did it conservatively. The patient is now about 8 months post-treatment. I don't have any neurology, doing almost entire work. Of course, I have cautioned him much more. Don't do this, don't do that. But he is fine with the conservative, only better. Thank you.
I think we have enough discussions. We should just move on to the tables. So you told that 4 to 5 people delegates are there on each models, and all the faculties are here to help you. The the company persons of Geon and Medtronic are here to help you with the instruments.
So I do a lot of scoliosis and deformity surgery, so I don't have the advantage of the C-arm there. The C-arm is useless in the scoliosis. So all my screws are freehand. Okay, so freehand involves nap. And the second is, like Dr. Sinha said, a full 3D anatomical perspective of the spine. Okay, having said that, the start of your surgery is to make a good exposure. I'm going to use this like a cautery. Make a good midline exposure, and with the cautery down to bare bone. So make a habit of stripping it down to bare bone with a cautery. So this all will look like a cadaveric exposure, and up to here we all expose quite routinely for laminectomy, so it's no big deal. इसके बाद थोड़ा we start getting worried कि laterally क्या होगा, isn't it? So after this you put in your self-retaining mastoid and use your finger to go on the side and feel the bumps, and you will feel bony bumps. The bony bumps in your mind should make this picture. It's the facet joint, and remember the facet joint configuration is like this. The superior facet or superior articular process is outside, the inferior is inside. So if I find a bump like this, I know what is on the outside belongs to the lower bone, what is on the inside belongs to the upper bone. This should get into your hand, into your head. Okay, sir? The next is that if I have to pass one screw, let's say in L4, I have to expose L4 and L3 spinous processes. If I have to pass in L5, I have to expose L5 and L4 spinous process. For L4, I don't need to expose L5. But if I don't expose L3 spinous process, I won't be able to get my facet joint. The next is that always remember that the pedicle is superior to the spinous process. So the spinous process is at this level, but the pedicle is going to be that much superior. Which is why you cannot expose this and pass that screw. You need to expose this and pass that screw. Is that absolutely clear? These are things that you cannot miss. If you miss this, then you've started on the wrong foot and all the other discussion goes haywire, right? So for the L4 screw with the cautery, I've stripped the L4 lamina. I've stripped the L3 lamina also. With my finger, I felt the bump. Okay. Now I have a bony island here. I have some mushy stuff here, and I have some muscle here. I'll ask my assistant to retract, and with the cautery start connecting this island to this island. So with the cautery, or this island, but this is easier. So I start buzzing and walking along the bone. So it's like if you have a pool of water and you see some land there, you start walking on the land that is going to connect to that, literally, because in between is water. Actually, there's just soft tissue here. But as you know, we are sometimes not. So basically, and you land on this bump. Okay. Once you come here with the cautery, start stripping away the facet capsule. Again, make sure that you're using the cautery. If you're not sure, once you've reached here, take a nibbler and hold this and do that. You will know which part of the joint belongs to this and which belongs to this. Okay, eventually you want to expose the superior articular process of the bone that you're going to put the screw in. So from the C1 to the S1 or the S2, the entry point of a pedicle is the superior articular process base. The base of the superior articular process is the entry point of a pedicle screw, and that's the final verdict, whether it's C1 screw or whether it's S1 screw. Okay, so with that in mind, you have to expose that superior articular process. Okay, so now that I've buzzed here and I've done this, I realize that this part of the bone belongs to this, and that becomes my SAP, superior articular process. Now I need to know which is the base of this joint, so I actually with the cautery go into the joint and actually see it like this. Now that I know with a nibbler, I will actually bite at that base. Got it? Like this. So the minute, and I keep checking, am I at the right place? So it's moving. The minute I bite this, I will find a pedicle blush. So I will find cancellous bone over here. It's called a footprint. I'll find little cortex, because this is a very thin thing, but this is the actual pedicle if you see laterally. So here at the base I will find a nice round hole. So with either a starting owl or any owl, I'll just make a little trough over here. Just a trough, like a footing. Bowler कैसे mark लेता है, because you don't want to slip. You want to create a little trough, no direction. Once I've done that, and I have a good footing,
Now I plan my screw. Okay, for my screw, I need an owl. This has to be it, and this is available for a few $1,000. Just buy it. So it has to have a nice ball end. It can't be a little thin end because you want to have maximum surface contact. It has to have a slight curve because it gives you the leverage to change directions. It has to have sharper sides. It shouldn't be rounded. A reasonably sharp tip, but not sharp enough to cause me bleeding. So it should poke you, but it shouldn't bleed you. If it's totally blunted, आपके पास blunt probe भी है, then it does not work. There's sometimes like a flat probe that doesn't work. Yeah, like this is not a good probe. So it has to just perforate through the cancellous bone without perforating through the cortical bone. Okay? नहीं, ये perfect. So this is called a Lenky out, and all companies make a slight curve. Okay? So what I'm going to do is I know my footprint. Okay? Now I have two questions to answer. One is what's going to be my mediolateral angulation, and what's going to be my supero-inferior angulation. Right? So mediolateral is in relation to the spinous process. Why do I say this? Because the patient would be slightly positioned like this. The patient would have a scoliosis, right? So where you see the spinous process, you should angulate medial compared to that. So if the spinous process was like this, you want to go like this. If the spinous process was like this, you want to go like this. Is that clear? It's a 3D orientation. Don't orient medialization to the world. It's medialization to the spinous process. That angle, how much is it? So you can never measure 15, 20, 30 on the table. So it should be more medial. It should be more medial than lateral. Okay? Luckily in the lumbar spine, there's so much muscle here that it prevents you from going too medial. Number one. So the worry of being too medial is not realistic in the lumbar spine. The other thing is that the pedicle is only 15 mm tall. It's only 15 mm tall. So to really perforate the pedicle, you have to be so like 40, 50 degrees medial, which none of us are going to be. We are surgeons, we are not butchers. Right? So आप 15 की जगह 20 या 30, 35 करो तो इतना कोई फर्क नहीं पड़ता. You followed because the pedicle is only so much. If the pedicle was so long, then that angle becomes very critical. In the thoracic spine, that's the fun. But here it's not so important, right? So anyway, my medial angulation is a few degrees. I'm going to say 15 degrees compared to the spinous process.
ये कर्व का तो डायरेक्शन
नहीं वो आगे बताता हूँ. I'll come to that. फिर supero inferior direction, it should be perpendicular to the lamina. So again the L5 lamina will be like this, the L4 will be like this, the L3 will be like this, the L2 will be like this, and L1 will be like this. So I have to be perpendicular to the lamina, and which is why I need to expose the lamina correctly. So here this will be the direction, here this will be the direction, here this will be the direction, there that will be the direction, thoracic and then upper thoracic. Is that clear? To the lamina. So ये lamina ऐसे है ना? हाँ, तो आप रखिए मैं आप फिर. So this is going to be my direction. इसको perpendicular 90 degrees. 90 degrees to the ऐसे नहीं होगा.
ऐसे नहीं होगा.
समझ गए? ऐसे होगा. And sacrum में और ऐसे होगा. L5 में ऐसे होगा.
sacrum में भी किसी प्लेट के पैरेलल होना चाहिए.
Sacrum का थोड़ा फंडा अलग होता है. पैरेलल नहीं होना चाहिए. इन प्लेट में घुसना चाहिए. You want a tricortical screw. Tricortical screw. Here you want them parallel to the end plate. In the sacrum you want it to go into the sacral promontory. So it's slightly. So if this was the angle in the sacrum, by this law you want to make it slightly flat. Okay. So now once this is done, अभी भी मेरी फट रही है कि वो अंदर जाएगा तो क्या? अपनी सबकी फट रही है. So I'm going to keep the curve facing outward. I know that this curve is about 30, 15 or 20 is whatever pass. So at that point, I'm going to keep it facing outward. My angulation is good. Okay. Now this is going to find its direction. Now this is what I'm doing now is the most critical thing compared to everything else. I'm not even looking down. I'm getting a feel. अरे अटक रहा है, तो I'll do this. हाँ, जा रहा है. So think of a blind man walking in a room. वो अगर दीवार को लग गया तो ऐसे करके अरे इधर कुछ है ऐसे करके घुस जाएगा ना. So this is that blind man. This is the eye and this is the stick. So this is going to tell me. So supposing I'm going here and I think I'm going. I think it's not going my track because ये force कितना लगा रहे हो. ठोको तो वो force ही नहीं है. It has to be force with your hand. It has to be grabbing and it has to move from 11 o'clock to 1 o'clock. Only that much. It can't move like this. It will create a big hole there. So this movement and a feedback, all the time a feedback. जा रहा है, नहीं जा रहा है. So I'll see, नहीं ये तो थोड़ा superior लग रहा है. Can you see? So I'll try it with you. Then जा रहा है, नहीं जा रहा है. अरे ये तो straight है, थोड़ा medialize करके देखो. Understood? So I'm walking my way through. I'm now stuck. Okay? क्या पता नहीं जा रहा है कि नहीं जा रहा है. Then I'll remove it, take a ball point. First of all, when I remove it, blood should come back. If blood is not coming back, means there's a hole where the blood is leaking out. So I remove it, blood comes back. I take this, I feel, Baba, it's inside. Happy. So I start again. There's no problem doing that. Okay. So once again, same. Until a point will come where I've crossed the 15 mm mark. It's going well. It's going well. It's going well. 15 नहीं हुआ है because this is 30 invariably. तो अपने को यहाँ तक तो जाना है. So I keep going. So this is where that experience comes. Experience of the feedback. Confidence and experience. The worst thing to do is hammer and doing C-arms. Because C-arms are okay in a normal spine, but there's so much radiation, AP-lateral, how many will you do? So personally, I can put screws from T1 to, or even C1 to S1, all the screws, and then last before closure do a C-arm. That's what I do in my private practice. Okay. So if I do it, it can't be that wrong. Okay, now देखो यहाँ तक चले गया. Maybe 15-20 तक चले गया है. Okay. So in my mind, I'm assuming it's crossed the pedicle length. इसके बाद अपने को तो बहुत medial जाना है, because if you see the axial view, जितना medial जाओ उतना अच्छा है. Unlike the thoracic spine, here there's a big receptacle. Thoracic spine तो ऐसे narrow हो जाती है. बाद में I'll show you a diagram on some paper. मेरे को paper pen भी लगेगा. To show the difference between the thoracic and lumbar. Big difference. So here, as soon as you cross the pedicle, you can go as medially as you want. So, understood, no? Because the bone is very big. So once I've crossed my 15 mm mark, so I was the other way, ऐसे था ना, pointing out. So once I cross that mark, I can take this out, turn it around. This is called a gear shift mechanism, but not turn it around within. It will become a big hole. बाहर निकालो, मोड़ लो, फिर ऐसे मत जाना, ऐसे जाना, because वो उस तरफ था ना, and ऐसे जाना, and then go all the way deep. And typically in a Indian lumbar spine, 40 to 45 तक जाता है इसको. 40 is also okay, because अपने को सिर्फ इसको क्रॉस करना है. Yeah, got it? सेक्रल स्क्रू में एक, सो ये क्लियर है फंडा. सेक्रल स्क्रू में एक ही फ़र्क होता है दैट ये जो इंफीरियर आर्टिकुलर प्रोसेस है जो इसको खुला छोड़ी है यहाँ पे पूरा कवर करती है. सो यू कैनॉट पास अ सेक्रल स्क्रू विदाउट ऑस्टियोटोमाइजिंग दिस. पेन है किसी के पास? यू हैव टू कट दिस with an osteotome. 10 mm osteotome, knock this off, expose this. So you see the superior articular process, bite the base and start putting your screw. The second problem is that here there's the ileum. And इसमें medialization like Ram showed you is critical. इसमें थोड़ा भी ऐसा गया तो यहाँ से S1 root L5 root आता है. So this screw has to end up here, not here. So medialization is very, very important. There's no worry because wide canal है, so you'll never be too medial, but you can be always too lateral. When you start doing medialization, the ileum comes in the way. So that's the other problem. So sometimes you even have to osteotomize the ileum. But just remember that is the problem. The third is that you don't want the screw to be in this direction. You want it to be in this direction. You want to hit the promontory, not the cortex. Because the sacrum doesn't have a pedicle. Sacrum is a large cancellous bone. So the only cortex you have is this ridge. It's called a tricortical screw, where all the three cortices meet. So this is the only screw that I would pass under CR. Where I'll get a great bony feel with my technique, but I may be in this bone and not in that. So here it's a good idea to pass your owl, check on K-wire, and then make sure that it's pointing there. Last tip. Here, if I don't put a tricortical screw, the screw is going to just come out. The screw has to cross the. Here you never put bicortical screws. Here, if it doesn't cross the cortex, it's a loose screw. It's a cancellous screw. So by law, it has to cross that. No shortcuts. So what happens is that you do this, and then you start passing your screw. So your owl is maybe 2 mm or 3 mm. Your screw is 6 mm. So the screw nicely goes, it hits the cortex and starts doing GFR. GFR, घूमता फिरता रही. It just keeps moving, it doesn't cross that cortex and a big hole is created. So the message is you have to tap this screw. After you've done the owl, put a K wire, see the direction. After that take a 4 mm tap, thin tap. The tap will walk through the screw but it will catch the distal cortex. If you want, even take a 5 mm to expand the distal cortex and then pass the screw. So it will walk through, it will not keep rotating, hitting the cortex. That's the specialty of the sacral screw. And thoracic का मॉडल नहीं है तो बहुत सारा बताना है thoracic.
डायरेक्शन कैसे?
So ultimately वही है कि आप base of the इसको bite करो, base of the articular process को. So that is your entry point. मान लो direction is medial. So say this is the entry point, medial and perpendicular to the lamina. So ultimately ये direction होगा. इसमें दो चीज़ बीच में आती है. एक यानी medial करने जाओ तो ileum आ जाता है. So उसको you have to figure out how to manage that. कभी-कभी ileum को तोड़ के या विंडो करके भी कर सकते हैं. Soft tissue सब कुछ. So but वो error नहीं होना चाहिए. Medialization का बहुत error हो जाता है और वो screw यहाँ आ जाता है. It's the लंबा. दूसरा है कि अगर ये रूल से फॉलो करो, परपेंडिकुलर टू द लैमिना, आपका प्रोमोट उसमें नहीं जाएगा, सेक्रुल प्रोमोट पैरेलल टू द एंड प्लेट जाएगा. पैरेलल टू द एंड प्लेट यानी ये डायरेक्शन, अपने को ये डायरेक्शन में चाहिए. सो एक बार ये अपनी डायरेक्शन तय हो गई तो थोड़ा सा कैफेलाइट डायरेक्ट. That's the yeah. हाँ.
सर टीपी जो पेज डालते हैं उसको करते हैं वो कैसे पेज डालते हैं?
Everyone wants to know that, so I'll explain. नहीं और कोई स्क्रू
सवाल ये था कि सर जैसे लिस्थेसिस में हम लोग जनरली मैं क्या करता हूँ कि यहाँ पर से जो लैप्रोटोमी करके कंप्रेस बोन मास किया है, फैसेट जॉइंट के पास लैटरल मास भी बोन कर दिया, इट इज़ ऑल्सो एक्टिंग एज ए बोन ग्राफ्ट. तो क्या ये नेसेसरी है कि डिस्क को हटा के डिस्क भेज दें?
नहीं, वो डिपेंड्स ऑन द इंस्टेबिलिटी. अगर अनस्टेबल स्पाइन है तो इंटरबॉडी फिक्सेशन इज अ मस्ट इन द लंबर स्पाइन बिकॉज अ लोड बेरिंग स्पाइन रोटेटरी अनस्टेबल स्पाइन. अगर अनस्टेबल नहीं है यानी कि लिस्थेसिस है लेकिन बंदे का एज 70 है, डिस्क स्पेस पूरा कोलैप्स हो गया है, फैसेट्स एकदम आर्थरेटिक है, फ्लूइड नहीं है फैसेट्स में, उसको बैक पेन कहने जैसे नहीं है और वो फ्लेक्शन एक्सटेंशन मूव नहीं होगा, उसमें PLF चल जाएगा. बट अगर 50-year-old स्पोर्ट्समैन बंदा है जिसकी डिस्क हाइट मोटी है, जिसके फैसेट्स में फ्लूइड दिखेगा, वो एक्शियल सेक्शन में वाइट दिखेगा और जिसको बैक पेन भी है, यहाँ थंब करो तो आउट रहेगा और फॉरवर्ड बैकवर्ड मूवमेंट में वहाँ मूवमेंट हो रही है, उसमें इंटरबॉडी इज अ मस्ट. एंड टू सिंपली आंसर योर क्वेश्चन, आपने सेक्रुल स्क्रू की ऑस्टियोटोमी देख ली ना, इट्स एग्जैक्टली द सेम ऑस्टियोटोमी टू गेट इनटू द टीथ. जहाँ पे भी हो इंफीरियर आर्टिकुलर प्रोसेस को तोड़ दो. द मिनट यू ब्रेक दैट, ये जैसे अगर यहाँ टी लिफ्ट करना है तो इसको तोड़ दो. जस्ट लाइक इसको आपने तोड़ा ना, इसको तोड़ा तो यू आर मेकिंग योर एंट्री इनटू द L5S1 डिस्क. उसके बाद क्या करना है, इसको तोड़ना है बस. सो सिमिलरली इसको अगर तोड़ दिया तो ये दिखेगा लाइक अ फैसेट जॉइंट, यू सी अ नेकेड फैसेट, तो उसको चबा लो.
अब ये डिस्क आ गया,
पेडिकल सुपीरियर पेडिकल बॉर्डर आता है और एग्जिटिंग रूट यहाँ से चले जाता है, वो दिखता भी नहीं. एग्जिटिंग रूट इज हियर यहाँ, तो वो दिखेगा भी नहीं अपने को. अगर हम लोग ने तो यहाँ काम
करते हैं तो
ये दिखता नहीं है. नो ये इतना यहाँ पे ये दिखता ही नहीं है बिकॉज आपका ऑस्टियोटोमी यहाँ है. आप देखो ना, दिस इज द ऑस्टियोटोमी. नर्व रूट इसको हग करके चले जाते हैं. ट्रैवर्सिंग रूट इसके यहाँ से जा रहा है तो वो भी नहीं दिखता. तो आइडियली दोनों रूट्स दिखने नहीं चाहिए. आइडियली ये इसको कट करो, ये दिख जाएगी सुपीरियर आर्टिकुलर प्रोसेस. उसको फॉरवर्ड पंच या निबलर से बाइट करो. कितनी बाइट करो अंटिल यू फाइंड रेजिस्टेंस. सो इफ यू स्टार्ट यूजिंग योर पंच एंड स्टार्ट कटिंग दिस, यहाँ पे रेजिस्टेंस आ जाएगा. सो इन द टॉप बॉर्डर ऑफ द पेडिकल. गॉट इट? नाउ रेयरली वो डिस्पेस एकदम दबी हुई होती है, वेयर इतना कट करके चलेगा नहीं. तो इसको भी खींच के ये भी बाइट बाहर से यू हैव टू कम अप टू दिस पेडिकल. जब वो नर्व रूट दिख जाता है एंड दैट इज अ सिचुएशन वहाँ गैंग्लियन होता है, उसके साथ छेड़छाड़ करो तो पेशेंट हैज लॉट ऑफ पोस्ट ऑप सिम्पटम्स. सो द डिस्क स्पेस इज कोलैप्स्ड, then it's a tricky procedure. So what I do is that इतना करने के बाद I put a 5 mm osteotomy and open up that disc space, gets little bit of widening and then do the TLIF. Got it, na? What other questions?
सर या अगर जैसे ये तो बताइए लेमिना पे परपेंडिकुलर डालना है, अगर डायरेक्शन के हिसाब से डालें तो मतलब क्रेनियो पोर्टल क्या डायरेक्शन होगा ऑल करने का, और मतलब
टोटली लैमिना के ऊपर डिपेंड होता है। आप मान लो कि पेशेंट ऐसे ऐसे पोजीशन हुआ है, तो आप वो एक डायरेक्शन लेके रखो ना कि 10 डिग्री वो फेल होगा। यू हैव टू, दैट्स व्हाई एक्सपोजर इज क्रिटिकल। आपको कैडेवरिक एक्सपोजर करना है, 1 घंटा लगने दो बट कैडेवरिक एक्सपोजर करना है। एंड एक ही ब्लीडर होता है जो यहाँ से आता है, फोरामिनल ब्लीडर, उसको ऐसे करके पकड़ना है, बाकी कोई ब्लीडर्स होते नहीं है। सो उसमें यू हैव टू स्पेंड टाइम, पील ऑफ द सुप्रास्पाइनस प्रोसेस, पील ऑफ, रिमेंबर द स्पाइनस प्रोसेस नॉट अ फ्लैट, इज लाइक अ फ्लावर। तो ऐसे करके उसको क्लियर करो। यूट्यूब पे अगर मेरा नाम डालो और PLF देखो, तो PLF पे मेरा पूरा टॉक है, उसमें पूरा डायग्राम दिखाया है जस्ट फॉर एक्सपोजर। बिकॉज आपने बताया कि जस्ट बोन, वैसे नहीं होता। PLF के लिए टू एक्सपोज द फैसेट, कट द फैसेट, दिस इज योर मेन फ्यूजन। यू हैव टू एक्सपोज द लैटरल सर्फेस ऑफ द सुपीरियर, क्योंकि बोन बहुत कम होता है। ये भी फिर यहाँ पे बड़ा लप्पा होता है मसल का, उसको फ्लैट करके इंटर ट्रांसवर्स फेशिया एक्सपोज करो। कट मत करो नहीं तो किडनी आ जाएगी। और उस पर बड़े बड़े चंक्स डालो, ब्रिजिंग चंक्स। दैट होल प्रोसेस हैज टू बी फॉलोड। सो राइट फ्रॉम हार्वेस्टिंग द बोन हैज टू बी हार्वेस्टेड इन चंक्स लाइक दिस, चिता जैसे बड़े बड़े लंबे लंबे पीसेस जो यहाँ से यहाँ फिट हो। Otherwise the surgery doesn't, the bone graft doesn't collect, doesn't fit. Just put Abhay Dene on YouTube and PLF lecture, you will find PLF, TPD, all lectures का videos आते हैं।
सर लंबर स्पिन पर जैसे बताया कि ये सुपर आर्टिकुलर फैसेट का लोअर पार्ट को कट करके वहाँ से एंट्री कर देना है, और थोरेसिक में भी
एग्जैक्टली सेम होता है। अगर पेपर है तो बता दो।
लेकिन ये वाला थोड़ा डिफरेंट लिखा हुआ है कुछ
थियरी नहीं, प्रैक्टिकल। आपका प्रैक्टिकल सोचो। प्रैक्टिकली लंबर स्पाइन, सॉरी मैं मेरी डायरेक्शन में ड्रॉ कर रहा हूँ, लंबर स्पाइन ऐसी होती है, करेक्ट। थोरेसिक स्पाइन ऐसी होती है, ये याद रखना चाहिए परमानेंटली। सो द डिफरेंस, इसका पेडिकल ऐसे होता है, इसका पेडिकल ऐसे होता है, नंबर 1। इन द नेक्स्ट व्यू लंबर स्पाइन ऐसे दिखती है। समझ रहे हैं मैं क्या, जैसे डायग्रामेटिक, इट्स नॉट अ वेरी गुड डायग्राम बट इट्स ट्राइंग टू टेल यू व्हाट इट इज। सो फैसेट जॉइंट इज आउटसाइड, दिस इज द एंट्री पॉइंट। थोरेसिक स्पाइन में कैसे होता है, है ना? तो इसका सुपीरियर के वजह से यहाँ पे छुपा होता है, आगे पीछे, आप समझ गए? इसका अगर ये T7 है तो T7 का आपको अगर सुपीरियर के मिलेगा ही नहीं, ये इससे कवर हुआ है,
मतलब T6 के नीचे
है। तो इसको ऑस्टियोटोमाइज करो, इस इतने पार्ट को हटा दो, फिर वहाँ वो दिखेगा खड़ा, फिर उसके बेस से डालो, समझ गए? सो देर आर 3 एंट्री पॉइंट्स फॉर दिस। और एक व्यू दिखाना है, पीछे दिखा या यहाँ दिखाना। थर्ड व्यू इज दिस एक्शियल व्यू, बिकॉज इन एवरी टाइम यू हैव 3 व्यूज इन योर हेड, लैटरल, PA एंड एक्शियल। तो एक्शियल में लंबर स्पाइन ऐसी दिखती है, थोरेसिक स्पाइन ऐसी दिखती है, कोनिकल एंड बिग कनाल। सो यू टू गो मीडियल। यहाँ पे एक बार घुस गए तो थोड़ा टेढ़ा मेढ़ा चल जाता है। यू सॉ द डिफरेंस? या सो इसमें 2 एंट्री पॉइंट्स होते हैं थोरेसिक स्पाइन में। पहला होता है जो सबसे सेफ है कि इसको ऑस्टियोटोमाइज कर दो, इसकी बेस को ढूंढो, आपको पता है बेस क्या है, बेस के मिड पॉइंट से घुसा दो उसको। खाली ये स्क्रू अगर डाल रहे हो तो ये बिल्कुल पेडिकल में जाएगा, बट अपना जो रूल था परपेंडिकुलर टू द लैमिना, वो रूल तोड़ना पड़ेगा, बिकॉज यहाँ पेडिकल का डायरेक्शन ऐसे होता है, ऐसे नहीं होता है, वो रूल इसके लिए था। आप समझ गए? सो दिस इज कॉल्ड एनाटॉमिक एंट्री पॉइंट।
अभी तो सर जैसे बताया T4 to T8 परपेंडिकुलर जाएगा,
बट वो अलग एंट्री पॉइंट है। आई विल शो यू दैट एंट्री पॉइंट। एनाटॉमिक एंट्री पॉइंट इज द सेफ एंट्री पॉइंट। आपने पूछे अपोथोरेसिक स्क्रू, दिस इज द सेफ स्क्रू एट T1 T2 पूरे under your vision, because you've exposed this now, you know the neural structures are medial to this. Exposed किया तो there's no question, so you can safely use this. When you have not exposed, you're blind, you don't know यहाँ पे nerve है, यहाँ पे कहाँ पे है। So यहाँ पे ले लो, अगर ये perpendicular आ रहा है तो go another 10 degrees down because perpendicular would go here. You want to go down because the medical points down. So ये ऐसे स्क्रू जाती है. इसकी खासियत और एडवांटेज है कि it is safe. It's under vision. Disadvantage is that the screws don't line up to the other screws. नीचे के screws ऐसे आए ये ऐसे तो वो थोड़ा सा but polyaxial में जल जाते हैं but that is what happens. Okay. So the surgical pedicle screw which you all like to pass when it's an easy thoracic spine, say T7, big boy. So we don't do this osteotomy. We imagine कि इसके नीचे वो है मन में हाँ और अपना एंट्री पॉइंट यहाँ होना चाहिए था इमेजिनरी लेकिन इसको नीचे घसीट के 1/3 2/3 जंक्शन यहाँ रीच होती है ऑलवेज रीच होती है यहाँ पे सो 1/3 2/3 जंक्शन एंड लैटरल एज ऑफ द सो इफ दिस वाज माय ओरिजिनल एंट्री पॉइंट माय सर्जिकल एंट्री पॉइंट इज हियर आप समझ गए सो इसमें आई हैव टू decorticate yeah so because it's inferior I don't have to tilt it down like it can come straight perpendicular but because it's lateral I have to converge more नहीं तो ये इधर फंस जाएगी और इधर क्या कौन होता है big blue and big red so you have to converge more understood and और एक ट्रिक है लास्ट अभी कि इसमें एक और चीज़ होती है thoracic spine में जो लंबो में नहीं होती है so this is the transverse process and that's the rib and rib is a big fat bone the rib has a costo-transverse joint and a costo-vertebral joint together this forms a big bony mass so there's another technique called in-out-in technique अगर ये दोनों अपने फेल हो रहे हैं या फट रहे हैं so you can use the in-out-in technique where we bite the spinous process the transverse process are like this उसको बाइट कर दो तो इट लुक्स लाइक अ लॉन्ग बोन विद अ कॉर्टेक्स एंड अ मेडुला जैसे फीमर छोटा सा और उसको इंट्रामेडुलरी नेलिंग करो वो जो ट्रांसवर्स प्रोसेस दिख रही है ऐसे होती है ऐसे नहीं होती है उसको बाइट करो उसके थ्रू स्ट्रेट आउट डालने लगो सो दैट गोज इन टू दिस कम्स आउट इन दिस कैप सो इट्स इन आउट यू फील अरे क्या हो गया then it hits this entire cortex junction and goes there. It's called an in-out-in technique. It is totally safe because it's way lateral. उसकी शुरुआत ही यहाँ पे होती है. So वो कुछ न्यूरो ब्यूरो को मैं प्रॉब्लम नहीं देता. बहुत लंबा स्क्रू होता है. The problem is कि बाकी के स्क्रूज यहाँ, ये स्क्रू यहाँ.
Connecting rod लगाने में.
Connecting rod में तकलीफ हो जाती है. That's the problem. Otherwise, a very I've seen Dr. Jaiswal using drill for that. So स्कोली वगैरह में it's a good rescue screw. So that's the third technique. So there's anatomic screw, surgical screw, and in-out in the thoracic spine.
सर ये जैसे ये लंबर स्पाइन में अगर डालना हो तो ऐसे भी डाल सकते हैं इसके मतलब कि मिड लाइन में आता है यहाँ.
So lumbar spine में एक दूसरी टेक्निक है जो मैं सिखाया should be a workhorse technique. But अगर your last screw like अगर I'm fusing L3 4 5 तो my L3 screw can't violate the facet. बिकॉज वहाँ सो वो स्क्रू सेम मेथड से हम लोग इमेजिन करके यहाँ से डालते हैं इसको हमने इमेजिन किया सिर्फ ये दो डाल दिए इससे अपने को वी हैव अंडरस्टूड द एनाटॉमी एंड हियर आई एम इमेजिनिंग बट गोइंग लैटरल and passing it from here exact same as this but again as per that you have to be more medial that's the rule so sometimes you can just cheat and इतनी अगर facet capsule है इतना चला दो और यहाँ से डालो that's sometimes easier than doing this because यहाँ पे bleeder भी आता है
अगर सर यहाँ थोड़े सी में डालना हो ट्रांसवर्स प्रोसेस के रिस्पेक्ट में अगर डालें तब कैसा रहेगा अपर 1/3 लोअर 2
नहीं वो इन आउट इन नहीं ये सर्जिकल है
लेके डालना है
नहीं तीन ही है एक एनाटॉमिक आपको समझ गया कटिंग द फैसेट एक सर्जिकल है जिसमें 1/3 2/3 आता है 1/3 2/3 एंड आउटर inferior process एंड एक इन आउट इन टेक्निक है जो यहाँ से जाएगा यहाँ से और इतना स्लोप होगा ये इतना स्लोप होगा ये इतना स्लोप होगा ये इतना स्लोप होगा सो ऐसे यहाँ पे रिब होती है सो आई एम बाइटिंग दिस यहाँ पे एक बड़ा बोन मास है बिकॉज इट्स अ कॉस्टो ट्रांसवर्स जंक्शन उसमें मैं घुस रहा हूँ बीच में से बाहर आ रहा है सो इट्स इन देन इट्स अ फीलिंग ऑफ गिव वे एंड देन यू एंटर फ्रॉम द लैटरल वॉल ऑफ द बॉडी एंड द मीडियल वॉल ऑफ द रिब एंड गेट इन दिस
बॉडी में एंटर करना
बॉडी में एंटर हो जाता है इतना लंबा स्क्रू है So in, out, in. This you have to practice on cadavers. Next you have to get a senior surgeon or experienced surgeon to come and wash with you without feeling shy or without having any ego. Or come to a senior surgeon. I'm not senior, but I'm experienced. I'm 51. So come to a surgeon who does this regularly to watch, and then do yourself. So that whole cycle has to be done. This is not at all good enough. Of course, you can see videos, but you have to be assisting someone when they're doing it. Then you should do and someone should assist, and then you should do it. And then it's very easy. You are welcome to come to our place anytime. Bombay को 2 दिन चले आना, काफी सारे screws दिख जाएंगे. And you can scrub up and all that, no problem. You contact Gautam, he will organize. Between me and Ram, आपको काफी surgeries wash up होने मिलेगी. Okay?
Thank you, sir.
So try to do this on your own.
Thank you. Thank you.